Assalamu alaikum everyone. I'm Talal Noor. I'm a fifth year medical student and I'm going to give you today the intro to Neuro. Okay? We're going to focus on the basics at the beginning. We're going to talk about the embryology of the brain, okay, how the brain forms, the very first beginning, and then we're going to touch upon the different cells of the nervous system, the nerves, and so many different things, okay? So let's start. Please stop me if you have any questions, all right? Okay. Okay, so let's start with neural development, okay? So we can all see, so back when when it's in the mom's, when the baby is developing inside the mom's womb, what happens is, first of all, we're going to have the notochord and the neural plate. Okay, that's where the nervous system will start developing. Okay, so what happens exactly? Okay, so you see this structure in here. It's going to eventually form the brain and the spinal cord. Okay, but how will it do that? So you can see in here we have something called the notochord. All right, and the notochord, it's going to stimulate the ectoderm, okay, to fold and form these plates. You see this plate, the neural plate above? So it's going to release, as you can see in here, the notochord is going to secrete sonic hedgehog, it's like a stimulator that's going to cause the neuro ectoderm, all right, to fold upon itself and form the neural tube, okay? So you can see how it's going to form, you can see, let's go back here. So this is the neural plate, and then when the notochord starts secreting the sonic hedgehog, it's going to fold upon itself, and once it folds upon itself, it's going to kind of form a tube, all right? So you know how it's like a straight like that, and then when it starts folding, it's going to form a circle, and this is the neural tube, okay? Now the neural tube, why does it keep doing that? Okay, so the neural tube, we're going to have, you can see in here we have the floor, and then we're going to have, we have the basal plate and the alar plate, okay? So what's the basal and the alar plate? It's just like the dorsal and ventral parts of the neural tube, okay? And why is this important? It's just because different like chemicals or stimulants are going to cause their progression and their growth, all right? What are these different things? In the basal plate, all right, we're going to have the sonic hedgehog is going to be secreted, and it's going to cause the further development of it. And then at the roof plate, we have something called the BMP, all right? And this BMP is going to result in the formation of the alar plate. Okay, but why do we have two different plates? Because these plates are there to form different structures. We have sensory structures and motor structures. You know how we have nerves that are responsible for sensory, like the sensation, the proprioception, all of these things. So the other plate, as you can guys see, is what's going to form these sensory structures. While on the other hand, the basal plate is going to result in the formation of the motor structures, all right? And you can see later on how it will develop and form the spinal cord. And I'm pretty sure you guys are familiar with this image, right? We can see the anterior horns, the ventral horns, and we can see the
Central canal.
Exactly, the central canal. Tamam? So this is just like a touch upon the embryology, all right? Or how we form from the notochord, okay, all the way into the spinal cord. Hello? So very fast, notochord is going to secrete sonic hedgehog. It's going to cause the neural ectoderm to basically like fold upon itself, forming the alar and the basal plate, all right? The basal plate is going to form the motor structure, and the alar plate is going to give the sensory structures. And these are basically stimulated by different chemicals. Tamam? Okay. So can someone tell me what is this structure here?
The dorsal root ganglion.
Do you guys agree? It's sensory.
Oh, wait, yeah.
Posterior brain horn.
Yeah, so basically, if you will look all together, wait, we're going to reach there eventually, but keep in mind that this is the posterior horn, this is the anterior. All right, because you know that the anterior is responsible for motor, and posterior is usually for the sensory. Tamam? Okay.
So dorsal root is.
Yeah, it's correct. Okay. Now, we said that the neural tube is formed, right? So you can see in here, if we look from top, and if we like kind of take like a coronal section, all right? We can see how we have we have the cavity walls, and we have three different compartments, okay? We have the forebrain, the midbrain, and the hindbrain, all right? So the forebrain is just the very top, the one that is at the beginning. So what do you think it will give rise to?
Cerebrum?
The cerebrum, yeah, because if you look in here, this is the forebrain, midbrain, then hindbrain, okay? And this is where all the structures are going to originate from, okay? So for the forebrain, okay, it's also called prosencephalon. So the prosencephalon is the forebrain, and it's going to give rise to the telencephalon and the diencephalon, okay? And those two structures are the main structures for everything in the brain itself, the cerebrum, okay? So the telencephalon is going to give rise to the cerebral hemispheres and the basal ganglia. And if you look at it, it looks like two structures. It looks like a bow, okay? And if you look at it, it looks like a bow in here. And this is going to give the two sides of the cerebrum, because you know how the brain looks? It's like two parts upon themselves. So if you can look at the two areas here, you can see that, it's going to eventually give us the cerebral hemispheres, all right? And then the diencephalon, I'm pretty sure you guys took this in Endo-Repro. Diencephalon, is this like word, like it's not very weird or new, right? So the diencephalon, what does it give to? It gives rise to the thalamus and the hypothalamus, all right? And then the thalamus and the hypothalamus, they control all of the processes in our body. They maintain homeostasis, and I'm pretty sure you guys have touched upon the thalamus and hypothalamus in Endo-Repro, right? Do you guys remember that? Even if you don't, that's fine. Remember it now, okay? So telencephalon is going to give us the cerebrum, okay, the cerebral hemispheres and the basal ganglia. Just remember the cerebral hemispheres. The diencephalon is going to give us the thalamus and the hypothalamus, okay? So this is everything for the forebrain, okay? So forebrain, it starts with F, it's the first. So first thing, we're going to have the cerebrum and thalamus and hypothalamus. Where do they come from? They come from telencephalon and diencephalon, all right? Tamam. Now we're going to go into the midbrain. Now the midbrain is easy because it's midbrain, and then eventually it's going to give us the midbrain. We know the structure of the midbrain, right? What is the midbrain?
It's part of this brainstem.
Exactly, it's the very first part of the brainstem. So we know that the brainstem is made up of the midbrain, the pons, and then the medulla, right? So the midbrain or the mesencephalon, and what's easy about it is that they all start with an M, okay? So mesencephalon is going to give us the midbrain, and then the midbrain is going to give us the midbrain again, okay? So this is easy. So we covered prosencephalon and mesencephalon, okay? So again, guys, what does the mesencephalon give rise to? Midbrain. And what does it give rise to again? Midbrain, okay. Now, last but not least, we're going to have the hindbrain, or the rhombencephalon, okay? Now, it's going to get a little bit more complicated here, but not too much, okay? So, it's going to give us the rhombencephalon, or the hindbrain. By hindbrain, we mean the very low part of it, okay? So, we have the cerebrum, like, created, all right? Cerebrum, thalamus, hypothalamus, the midbrain. So what are the structures that are left that you guys know of? Brainstem. We have the medulla, we have the pons, and then we have the cerebellum, perfect, and then we have the spinal cord, right? So everything, all of these structures are going to be formed by the rhombencephalon, but this rhombencephalon is going to give rise to two things, the metencephalon and the myelencephalon, all right? Now, metencephalon, okay? So think of it this way. We did the mesencephalon as in the midbrain, right? Then we're going to go to the metencephalon, okay? So the S comes before the T. So mesencephalon, midbrain. Metencephalon is the thing that's below, what would it be? What do we have below the midbrain?
Pons.
The pons. So we're going to have the metencephalon is going to give rise to the pons and the cerebellum. And if you guys remember how the brain look, I should add the brain, wait. I just wanted to show you that if we look at, I think I have it down the line. So if we look at the brain, do you remember what's around the pons? So basically we have our midbrain, and then we have the pons and the medulla, and then behind them, we're going to have the cerebellum, okay? So keep this in mind, that, okay, metencephalon is going to give rise to the pons. And what do I have behind the pons? The cerebellum. So metencephalon is for pons and cerebellum, alright? So what's left? We have the medulla left, and we have the spinal cord, right? So myelencephalon, if you think of it, myelin, and it has the word myelin. You remember the myelin sheath that goes around the nerves? Where do the nerves originate from? Spinal cord. So the myelencephalon, it will give rise to the last part of the brainstem, which is the medulla, which will eventually go into become the spinal cord all the way down. Okay? Is this clear?
Yes.
Okay, yalla, let's revise them as here. We have prosencephalon, mesencephalon, and brombencephalon. What will the prosencephalon give rise to? Telencephalon and diencephalon, right? So these are the very first structures. So what is the telencephalon? What will come up from the telencephalon? It's two, so the cerebral hemispheres. Good. Diencephalon, we said we took it in endoreper, so it's going to give rise to hypothalamus and thalamus. Perfect. Then we have the midbrain. Sorry, I gave it away. We have the mesencephalon. What will it give rise to?
Midbrain.
Midbrain. Okay. And then last but not least, we have the rhombencephalon. It's going to develop into two structures. What are they? Metencephalon and myelencephalon. What will we have from the metencephalon?
We're going to have the pons.
And the cerebellum. Perfect. And then the myelencephalon, medulla, and then eventually the spinal cord. Perfect. You have to get all the embryo questions right. Okay. Now, we talked about how the neural tube and the notochord and all of these structures form. Okay? And this all happens in the mother's tummy, okay, where the baby is progressing and growing in the fetal life. Alright? So we have something called neural tube defects. Okay? These neural tube defects, they happen usually, they're congenital. And when we say congenital, we mean they happen when the baby is growing inside their mothers. Okay? So what happens is, we talked about our neural tube formation, right? Now the neural tube later on, it will form, we said it will form all of these different things that we just talked about. Then we're going to have at the end the medulla and the spinal cord, right? Now what the neural tube defect is, we're going to have a defect where the spinal cord, or let's call it neural tube, okay? So the neural tube is going to be the structures that usually make up the neural tube will have defects. Now let's look at the normal anatomy, okay? So usually we're going to have the spinal canal in here, okay? And then it's going to have the spinal cord. This is the vertebra, right? And then in the middle we have the basically, what did you say?
Vertebral canal.
Yeah, we have the vertebral canal. Perfect. So we're going to have the vertebral canal. And inside the vertebral canal, we usually have the spinal cord, right? So this is the normal anatomy. The bone is going to protect the spinal cord. And then we have the skin. And these are the processes that you usually can palpate if you basically do any physical exam for the back, right? Now, in neural tube defects, it's basically something that will happen around the week 4 of development, which we know is the week where where all of these developments that we talked about will happen. And something is going to be missing. So we have many different kinds. We have spina bifida occulta, we have meningocele and myelomeningocele. Now, what's the difference between those three? The difference is the involvement of structures. Okay? So can we look in here in spina bifida occulta? So what do you think is the problem? What do you see? What's the defect that you see?
The unclosing of the vertebra.
Okay, so you see in here we have the transverse processes usually. Is this a transverse process? No?
Vertebral arches.
Oh, vertebral arches.
Labinas.
Oh yeah, okay. So the vertebral arches usually they're protecting the spinal cord. Okay. So in here we can see that there's a defect in the arc that's allowing the spinal cord to kind of be exposed. All right, but it's not going out. Okay. So in a spina bifida occulta, usually the problem is that we are going to have a defect in the arc, the vertebral arc, that's going to expose the structures in here. But if you look at the other one, nothing is going out. Like the structures are not bulging out. Okay, so this spina bifida occulta is the safest out of all of them. All right. And usually it presents with a tuft of hair or a skin dimple. So when the baby is born, they usually inspect their back, and they can see like a tuft of hair or a dimple, and then later on they can do more tests, and they can find the spina bifida occulta. All right. Now meningocele, okay, from the name meningocele. So we have what's the meninges?
It's the protection of
Coverings, exactly. So it's the structures that usually cover the brain. So a meningocele, it's basically the protrusion or it's the defect that allows the meninges to go out. And you can see it clearly here. So basically in the spina bifida occulta, nothing was protruding outside. But in meningocele, the meninges are going to be protruding, all right? But as you can see, the spinal cord is still intact and it's still in its place. So it's not protruding. It's only the meninges, okay? And we're going to have a skin defect. Is this clear? Do you guys have any questions?
Skin defect.
Okay, wait, let me show you.
we're gonna have an outer cyst basically.
It's going to be released it's called a meningocele. So seals are usually protrusions or it's gonna be protruding, alright? And we're going to have a skin above it, okay? So the meningocele is we're going to have. So this is the protrusion that you see at the end of the back of the baby. It's going to be basically made up of what? It's going to be the meninges, okay, covered with skin. So this is the defect. Usually the skin is smooth. It's like a bag, exactly.
It's like a bag.
It's a hernia, right?
In a way, yeah. No, we can't say it's a hernia, but the concept of a hernia maybe, okay?
Why can't we? Sorry.
Why can't we? That's a very interesting question. I don't know.
Because the hernia happens when an organ is basically going outside of its place. Like for an example, we have
a hernia. You can think of it like it's herniating, but it's not a hernia. I don't know. What do you think, Dr. Yaqeen?
Hernias are mainly related with abdominal cavity.
Yeah.
You have
Abdominal
abdominal
wall.
contents or abdominal wall is defected, or inside the abdominal cavity any organ is moving out of its place, is usually a hernia. When we talk about neuronal tissues getting exposed, it's usually a seal. And also when it is outside the body, it is usually the seal. You would also see varicoceles.
Oh yeah.
So similarly, when it is outside the body, it's
So it's
not
gonna
a
be like a
GI organ or
fair.
GI structure or abdominal structure.
Yeah, it's
Then
not
you
like
usually use the word seal rather than
hernia.
hernias. You think?
I agree. But the only thing that's kind of on my mind is that the brain, we call it herniated brain. So
Yeah.
brain does herniation,
Yeah.
but
Yeah.
you don't call herniation for the
For
actual
structures.
neural tube.
Yeah, and everything that's with so neural structures, we're talking about how the meninges are protruding, okay? And later on we're going to talk about the myelomeninges. So anything that has to do with the neural tissue and the organ, it's going to become a seal, okay? Because it's a protrusion outside the body. Now in a hernia, we're having an abdominal wall defect, and the abdominal organs are herniating outside. That's why it's like an abdominal hernia, okay? That's kind of a way, and then we're going to later on talk about the brain itself can herniate. Like, what does hernia mean? Like the word itself, hernia.
A protrusion of the
Organ. It kind of goes like away from where it has to be, right?
Yeah.
So like an abdominal hernia, the intestines and everything has to be inside the abdominal cavity, but they're protruding outside. Okay. In here, we're going to just stick to a seal, like a seal. Okay, the meningeal seal. Tamam? Is this clear?
yes, thank you.
Okay.
The
Now-
other thing that you need to mention that these neural tube defects happen because of the caudal neuropore. You know, the lower part of the neural tube usually closes. You know, if it doesn't close, then
That's
you
what
have
happens,
the
yeah.
neural tube defects.
It happens also at like 25 to 27.
Yeah.
I guess.
I think it's there. Oh no, it's not.
Yeah, it says 4-3. Yeah.
Okay.
Isn't
So
there,
yeah.
sorry, one last
No,
question.
sure.
Isn't there a difference between whether like the tube doesn't close like caudally
Fully?
or rostrally?
Yeah, we're going to talk about this in the next one, okay? So
Sorry.
this, like, in here, what's happening is the end of the neuropore is not closing, and that's why we're going to have the neural tube defects, all right? In the next slide, we're going to talk about anencephaly, where basically it's the anterior part of the neuropore that's not closing. So we're going to touch upon that. Let's
Thanks
just
so
finish
much.
this, okay?
One
No.
last question. So
Yeah.
this is the rostral part of the neurospore that is not closing.
Yeah.
Which is the
The
inferior.
lower part.
Yeah, the
The most,
inferior.
yeah, exactly. Now, we finished the meninges seal from the name. Meninges are protruding, all right? And they're covered by skin. Then, we're going to have the myelomeningeal seal. Now, again, we said myelo. What does it have to do? It has to do with the spinal cord, right? So we have the spinal cord and its meninges protruding outside. Now, this can be, so we're going to either have a thin skin or an absent skin. So it's either going to be like, you're going to see the meninges and the spinal cord protruding outside, or they're going to have like a thin skin above it, okay? So is the difference between a meningeal seal and a myelomeningeal seal clear?
Yes.
Okay, what's the difference?
Alright, I can tell. So we're gonna have the meningeal seal, basically where the meninges of the spinal cord are gonna be protruding outside,
Yes.
and they're gonna form like a cyst or like a bag
Like a
outside
seal,
of the cord.
okay.
And in meningeal seal, myelomeningeal seal, basically not only the meninges but also the myelin are gonna be
Which is the
outside,
spinal cord.
which is gonna form a cyst that is gonna be outside.
The other thing with the seals is that there is a water fluid bag. You know, it's
Yeah.
a cystic type of cavity. In hernias, there
They
is
don't-
no cystic bag. You know,
Yeah.
there's no cavity with fluid.
Yeah,
Okay.
because of
Whenever
the
you are going to use the word seal, there would be
Like a bag.
fluid-filled cavity or bag.
also doctor, because of the reason why it's also filled with that because of the cerebral spinal.
CSF.
Yes, CSF.
There is CSF there, subarachnoid spaces.
I wanted to see if it's. Oh. If we can see them like through. So.
Just a click. Yeah, you can see that the bag is there.
It's too advanced, I think.
You can see this one here, the one with the myelogram.
This one?
No, no,
Which
down,
one?
down. Go down.
Oh, this one? This one?
Go down.
Oh, sorry. Down.
Down, 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 down. MRI based image, you can see that.
Oh, yeah.
Yeah, that bag would tell you
Yeah, you can see that here.
the
Like.
CSF is all inside the bag.
So it's like a bag of water in a way, you know? It has a fluid inside, which is the CSF. This is, if you can see that the neuronal structures are not protruding here. So what do you think this is?
This is the meningeal seal.
Meningeal seal. But if we see the, okay, let's see if we're going to find the myelomeningeal seal. I think we can. Look at, I think this one is a myelin. Yeah. You can see that some of the neuronal structures are protruding with the CSF. So this is the myelomeningeal seal. Is it clear?
Yes.
Okay, perfect.
Yes.
Let's go back here. So we finished so if we have an issue with the rostral part of the neuropore, we're going to have neurotube defects. But what if it happens caudally, or like at the most interior or the top? Okay. What?
Cranially.
Cranially. Oh yeah, cranially.
Or rostral as you read.
Yeah. So in here, what happens is we're going to have the rostral neuropore is not going to close, okay? We're not going to have a forebrain. And we're going to have an open calvarium. What's the calvarium? Calvarium is basically the bone that usually covers the brain. So we're going to have no forebrain, an open calvarium, and that's how it's going to present. And this is called anencephaly. All right. So there is no forebrain and open calvarium. Okay. And this usually happens with polyhydramnios, but I don't think you guys like that, so just ignore those parts. Okay, so just know that anencephaly happens in the cranial part, okay, or in the rostral neuropore, okay, and it usually causes no forebrain and open calvarium. Is this clear?
I'm a little bit confused. Okay, so didn't we say that the...
It was coded there.
Not
Yeah, coded, meaning the last part of it. Here it's in the rostral, or in the cranial part. Okay, yeah. Is this clear? Yeah. Is it clear up until now? Yes? Okay. Tamam. So I put a normal MRI here just because we're going to talk about the next one, which is prosencephaly, okay, and lessencephaly. Now, the normal MRI here, you can see that we have our cerebrum, we have the third ventricle, or like the place in between the third ventricles and the lateral ventricles where the CSF is flowing. You can see all of these structures in here. Now we're going to talk about prosencephaly. Now for prosencephaly, okay, hollow prosencephaly, my bad. Okay, so hollow prosencephaly, what happens is that we're going to have midline defects, okay? So what happens is, okay, the brain did not divide, okay? So you see how in this image, look in here, let me show you. So in here, you can see how we have two perfect halves, where in here we have the cerebrum, in here we have the ventricles, and everything is symmetrical and everything, so it divided into two, all right? But in hollow prosencephaly, it did not divide into two, and it's just like a flat on brain, like it's all together, all right? So in hollow prosencephaly, it did not, the septation and everything did not happen. So we're going to have, like, you see, can you like point out the difference between this MRI and the previous MRI? Is it clear? Yeah.
Connected together.
Exactly, it's all connected.
What about the ventricles?
Exactly, you can see the ventricle is like a big bag right in the middle. So usually what happens is, just put this here. Okay, so what happens is, let's imagine this is our cerebrum, okay? Because it's made up of two halves, okay? So usually it's like one, and then eventually it differentiates and becomes two, okay? And this is how our cerebrum looks in our brain. But in here, it did not differentiate into two, and it's just like a one bunch, like it's all together, like neuronal tissue are all together. There's no clear differentiation between left and right side, so it's just all together. And you can see clearly the ventricle is all, like the lateral ventricles, if you look at them here, okay, you can see how they're like septated, and we have two clearly defined ventricles, but in here it's all one, all together, okay? So this is what hollow prosencephaly is, okay? And this is also it's like anencephaly, so it's usually, the problem is in the caudal neuropore, it's not fully, like it did not form in the normal way, فبصير في عنا this. And you can see how we're going to have midline defects. So you see how we have a cleft lip or palate, because you know how basically when we develop, we're going to have like two nostrils, like you know how we're like, do you get what I mean? Okay, so we're gonna have the cleft lip and palate. Usually they fuse together and then they form the lip. So because they're not able to fuse and all of the structures that usually give left and right are not there, what happens is we're going to have the cleft lip, the palate. We're going to have cycloopia. Cycloopia. Do you know what cycloopia is?
Like the connected eye?
Yeah, it's like one big eye. Okay.
Wow.
Yeah, it's scary. That's what cycloopia is. And they're going to have increased risk of pituitary dysfunction. And why do you think that would happen?
They can live or no?
What?
They can live or no?
I think their prognosis is really poor. Like it's not really good, because they're not gonna have like a fully formed basal ganglia, their pituitary, they're going to have pituitary dysfunction. They're going to have a lot of like congenital abnormalities. Come on. So this is holoprosencephaly. Is this clear? So we took anencephaly, which basically there's no forebrain. It's just the apencalvarium. There's no brain. Like the pore did not close it. The formation of the caudal pore was not there. So the forebrain was not. You remember how we said telencephalon, diencephalon? So all of this did not form. So we don't have a brain. And in here, the brain formed. But what happened is that they did not differentiate into the two, and we're going to have this like mush of all together, and we're going to have what's called as holoprosencephaly. And from the name holo, it means like you can see how. Do you see how the ventricle is? So basically, when I showed you the normal MRI, which was right here. Do you see it? Okay, you see how it's like the ventricles are like they form like a butterfly shape. Do you see it? Like it's like this, but then there it's just like a all together, like a hole, like a holo, you know. Khalas?
So we don't have 4 ventricles basically. We have one big ventricle.
In here, yes, we have like it's just like all together. All the ventricles are open to each other because that's what happens in here. Then we're going to have lesencephaly. All right. So in lesencephaly, the problem is that the neuronal migration that usually happens. So you know how we have neural crest cells. You know how they were going to migrate and form. So what happens is they're not going to migrate into their like specific positions, and then we're going to have this brain. So can someone tell me what's the difference between this image and the other image? Like what's lacking? It's really clear.
I think
The gyri and the sulci, exactly. It's just a smooth brain. There's no gyri, there's no sulci, and
ventricles are huge.
Exactly. So you can see that this in here is just a smooth brain, and it's big. And there is no gyri, no sulci because of the lack of neuronal migration. Okay? Now, these patients are going to present with seizures because, you know, like the brain is not fully like developed, or they're going to have abnormal activity in the nerves in the brain, so we're going to have seizures. They're going to have microcephaly. Does anyone know what microcephaly is? Small, exactly. So their head and their brain is going to be small. So it's going to be like a small brain, a small head actually, okay? Facial anomalies, they're going to have congenital abnormalities, and they're going to have, as we said, seizures because of the neuronal dysfunction. You know, the neural migration is not there, so we're going to have a lot of absurd neuronal activity. And last but not least, dysphagia. Do you know what dysphagia is?
Inability to swallow.
Exactly, so they're going to have an ability to swallow. Tom, is this clear up until now?
Yes.
Okay, so now that we finished the embryology part, okay, we're going to talk, yes, sure.
Please use the mic.
Oh, you can't hear me, sure. Okay, so now that we finished the embryo part of this, okay, we're going to go into the cells of the nervous system. You have something to say?
Just try to be more precise, more concise. This one course probably the most important part.
Yeah.
The last hour will be time.
Oh, you mean
This is not full picture. You're doing well.
Yeah, okay. Alright, now let's go over the cells of the nervous system, okay? So we have a central nervous system, we have a peripheral nervous system, right? So the central nervous system, we have, okay, what are the cells that you know of the central nervous system? Neurons, okay, but what?
So, we have oligodendrocytes.
Okay, so we have the neurons. These are like the big bosses, but we have a lot of supportive cells too, right? What are these supportive cells? We have the microglia, okay, and as you can see from what I included, it's kind of the protective cells of the brain. So they are like, you know how in our blood we have the white blood cells, we have the macrophages, all of these things that protect our body. The microglia are there to protect the brain. So they are kind of they go out and they scavenge, they go like on scavenger hunts, trying to search for any bacteria, any harmful things that are going to hurt the brain, okay? And then we have the astrocytes, and you can see the broom that I included, because they basically are the homekeepers, okay? They make sure that everything in the brain is well. They make sure that they get rid of all of the waste material. They make sure all the nutrients are there. They make sure everything is there to support them, all right? So think of the microglia as the protectors, okay? And the astrocytes as the homekeepers, okay? They clean, they provide the supportive environment, all right? And then we have the ependymal cells, and I include tears with the ependymal cells. Like you can see tears going down from them. It's just because they produce the CSF, okay? So ependymal cells are there. They usually line the walls of the ventricles to release the CSF, okay? And they're even found in the ventricles. They line the ventricles, all right? Last but not least, in the central, we're talking now about central nervous system, yani in the brain, all right? So we have the oligodendrocytes. What are the oligodendrocytes?
They make the million sheath of the
CNS, perfect. They myelinate the CNS. So as you can see in here, oligodendrocytes, they're providing the myelin sheath to multiple nerves, just making sure that I added the flashlight just to make sure that the central nervous system is firing really fast. Because what does the myelin sheath do? It basically increases the speed of the the impulses, neuronal impulses. Okay, so this is the central nervous system. Is it clear? Now for the peripheral nervous system, we have two cells. Now when we say peripheral, what do we mean by peripheral? Exactly, so basically we have the peripheral nerves, is it clear?
Yes.
Tamam. So we have the satellite cells and the Schwann cells. Now satellite cells and Schwann cells, they're literally the sisters of, or brothers, but they are closely related. So the satellite cell is closely related to the astrocyte. So it's كمان the homekeeper of the peripheral nervous system. It makes sure that there's no, it cleans up the environment, makes sure it has nutrients, everything that the body needs for support. And Schwann cells are literally the brothers or sisters of oligodendrocytes because they do the same thing, they myelinate the peripheral nerves. But what's the difference between oligo and Schwann cells? Like a very important difference.
Oligodendrocyte myelinates many neurons.
Perfect. So oligodendrocytes, from the name by the way, oligo is a lot. So oligodendrocytes, they myelinate a lot of different tissue, like a lot of different like axons of nerves, while Schwann cell just wraps around one axon. Okay? Is this clear? That's the main difference. Well, other than the fact that one is in the central nervous system, the other is in the peripheral. Okay? So, you can see it. Okay, so as we said, astrocytes, they are the homekeepers. Now, oligodendrocytes, there's a very specific thing about it, or like what they call pathognomic, or something that pops out, is that when they look at the cell under the microscope or histologically, it gives a fried-like appearance. And from the name oligo, and you can imagine like it's oligodendrocytes, like there's an egg, okay? So if they showed you a picture, and I'll show you the picture right now. If they showed you this, you can see the resemblance, fried-like appearance. What is it? Oligodendrocytes, all right? This is important maybe for OSB. I don't know if they do that, but yeah, it's very pathognomic. And then we have the ependymal cells. We mentioned they produce the CSF. You can see they have cilia and microvilli. They circulate the CSF, try to make it they produce it and they try to push it around. All right. And but we have ependymal cells. They have to do with the CSF, but what do? They circulate the CSF. They what is it called? They absorb the CSF. But we have very specialized ependymal cells that produce the CSF. And do you know the name of those cells?
Sorry?
The name of the specialized ependymal cells that secrete CSF. Okay, it's called the choroid plexus. All right.
Choroid epithelium.
Yeah. They call it the choroid plexus. It's usually found in the ventricles. They line the ventricles, and they're the ones that produce the CSF, right? So that's it for ependymal cells. Microglia, as I mentioned, they are there to protect the brain. They when we have inflammation, when we have inflammation, just think of microglia because they're going to be there. They're going to basically release the inflammatory mediators and they're going to make sure that everything is okay. Okay? We're back to the eggs, I think. Is this normal? Oh. Okay. Now we finished talking about the CNS and the PNS cells. So now we're going to talk about the actual nerve impulse, okay? The action potential, the neuronal action potential. And it's kind of, you already took MSK action potential. You know how like for an action potential to happen, there's always movement of like sodium, potassium, these molecules, or actually they're ions, right? Yeah, they're ions. Okay, so these ions have to walk around or like go up or down the like gradient to result in the action potential. So the same thing happens in here. So we're going to talk about this. So the neuronal action potential, let's take it step by step. So we all know that in every single tissue we have a resting action potential. Okay, and usually what is the most important ion in the action potential, like the resting membrane? So what is the one that's potassium, okay. So in here, we know that the neuronal tissue, they are more permeable to potassium than sodium at rest. So that's why potassium is usually the king of the game in here, all right? And during rest, the voltage-gated sodium and potassium channels are usually closed, okay? And the only thing that is kind of taking control of the action potential or the potential is the potassium. Hello? Then what happens is when we have when we need a neuronal impulse to happen, what would happen? So we're going to have membrane depolarization. So we have a resting membrane potential, okay? We want to change that membrane potential. We want to excite the nerve. We want to do something, all right? So what happens is the sodium activation channels, they're going to be activated. They're going to open, okay? And they're going to allow the sodium to go in. Okay, now if you look in here, you can see the resting potential, and here it's at negative 75. You know about KPA or something like that each ion basically will try to like, since I said potassium is the big boss at the resting membrane potential, so potassium itself has something called KPA or something like it has a value, which is its own value. But what happens is it's going to try to take the action potential closer to its value, okay? So for the potassium, it's somewhere beside the negative side, like negative 75 or like somewhere there. So that's why we have our resting potential at negative 75. Then what happens is the sodium channels are going to open. So we're going to have activation of the sodium channels. Sodium channels open and sodium is going to gush in. Sodium is positive, Na plus, right? So it's going to increase the action potential, it's going to become more positive, okay? So you can see the membrane depolarization, or like number 2 in here, so sodium, so look in here, this is the activation, the channel activated, okay? This is the activation gate. So the activation gate opened, all right? And the sodium is going to gush in. Now, as it gushes in, what happens is that we're going to increase the membrane potential all the way up. It's going to become more positive because more positive ions are going inside. Okay? And then it's going to go above the threshold potential. And do you know what the threshold potential usually means?
16.
No, what does it mean? Not the number itself.
Basically, it's the point where if you exceed it, the action potential can actually happen.
Exactly. So basically, what happens is the sodium is trying to raise it from negative 75 into the threshold potential to stimulate the neuronal impulse to happen. Okay. So it's going to go all the way up. It actually exceeds the threshold potential a lot. Okay. And it's going to reach a point where we have a lot of sodium inside. Okay. And when we have a lot of sodium inside, the inactivation gate is going to be activated. It's okay. Focus with me. Inactivation gate activated. So it's going to cause the gate to stop working. So you can see this. You see this circle? There's a line in a circle. So this circle is going to plug into the opening and prevent it. It's like like when you bath and then there's this thing you put the plug. It's the same thing. So it plugs it in, prevents sodium from going inside, and that's where basically the impulse is going. Okay, خلاص impulse is sent. and now we want to go back into the normal. So how do we go back to the normal? What happens is we want to repolarize the membrane. So what happens is potassium is no longer going to go in, and because we have a lot of positive inside, the positive force is so high, the potassium is like, I need to go back into the negative membrane potential that I had. So it's going to open, the potassium gates are going to open, and then the potassium is going to leave, and it's going to go back to becoming more negative, and then it's repolarized. Alright? Is this clear? It's easy. Come on. Now let's talk about the different, let's talk about the different sensory receptors that we have in our skin. So you see this is our skin, the epidermis, dermis, hypodermis. We have different sensory receptors, because if you think of it, sensation is a spectrum, right? You don't, basically when someone pinches you, it's not like when someone taps your shoulder, or when you add the temperature, it's not like when you blow on it, okay? So we have different receptors that will pick these stimuli, okay? So let's start with the free nerve endings. Free nerve endings are usually at the very top of the skin, and they are responsible, so think of it, if they're very top of the skin, what are they going to detect? Pain, exactly. So basically they're going to be able to detect pain. So if you pinch someone or something and they feel pain, what is activated? The free nerve endings. So we have pain, and if there is any difference in temperature, they're going to start fire like sending signals like, oh, it's hot, oh, it's cold, whatever. Come on. This is for the free nerve endings. Why does it do that? Okay. Now moving on into the Okay, next we have the mesenteric corpuscle. Okay? You can see it that it's deeper at the dermis. So what do you think it might think? It's a little bit deeper. So it's not going to be pain, it's not going to be temperature. What is it going to be? Pressure, okay. What comes usually with pressure?
Vibration.
Okay, touching, come on, and vibrations. So what it does is it detects vibration, and because it's at the dermis, which is like an upper layer, so we have the epidermis, dermis, and then we have the hypodermis. So it's in an intermediate layer, let's say, because the epidermis is the very top one. So it's going to detect low frequency, okay? Because it's at the top, it can easily, like if you do this, it's going to detect it, alright? And another thing it's going to detect is, as you said, fine touch, okay? So if you touch someone, it's going to, this touch is basically absorbed by the mesenteric corpuscle, okay? Moving on, we have the Pacinian. What does it do though? I'm sorry. Anyways, we have the Pacinian corpuscle. And if you look at it, it's open and deeper. And it looks like broad, okay? So what does it detect? And if you look at it, it looks like beats. I don't know if you see what I see, but it looks like beats. So it detects high voltage, okay? High voltage of frequency, okay? So mesenteric corpuscle is there for low voltage, and high voltage is the Pacinian corpuscle, okay? And also it detects pressure because it's way down. So when you pressure something, okay, if you're at the top and if you just put your when you want to add pressure on your skin, you have to go deep, right? So what the Pacinian corpuscle is like way down in the hypodermis. So, and if you look at it, it's like a circle. It's like a circle of beads, and I added this pressure like detector, and it's a circle. If you see the circle, just remember this pressure like detector, alright? So this is what the Pacinian corpuscle do. Last but not least, we have actually two more cells, the Merkel cells. Merkel cells is there for pressure too, but it's for lighter amount of pressure, alright? So it's at the top, so we have, the pressure is like a spectrum. So when you add the pressure on something, like, okay, if I want to add pressure here, okay, I'll start by poking the very first layer and going all the way down. Okay, so what is it called? The Merkel cells and the Pacinian corpuscle together are going to detect the pressure. Okay. Last but not least, we have the Ruffini ending. Okay, and if you look at the Ruffini, what does it remind you of? Muscle. Okay, and muscles. When you wanna like activate a muscle, or when you wanna like, what do?
Stretch.
You stretch. So basically, the Ruffini endings are there to detect any stretch in the skin, or it's like anything that you stretch. And you can see the scalp is stretching, and it's like, you can think of it like it's Ruffini. You can call the cat rough, and it's rough is stretching, so it's there for stretching. All right. So this is it for the cells. the specific receptors. And this is how they look in first aid. Like this is the free nerve endings, pain and temperature. The corpuscle is for low frequency vibration, for light touch, fine touch. The senior corpuscle is for high frequency vibration and pressure. Merkel disc command for pressure. And deep static touch. Deep static touch is like when you get like a knife. You know, when you wanna, you get the knife and you know how the knife is pinpointed at the end? If you just put the pinpoint there, what would detect this pinpoint, or like that it's sharp, is basically the Merkel's disc. Tamam? And last but not least, we have the Ruffini corpuscle, as we said, and it's there for stretch, and joint angle change, and remember our caltrough, okay? Moving on, we finished the central. Now the peripheral nerves, we need to know that the nerves have a covering. Okay, for the nerve coverings, we have the epineurium, perineurium, and endoneurium. Let's start from the very, bottom up, okay? So you can see the nerve fiber. The nerve fiber, when the nerve itself is made up of a bunch of nerve fibers, okay? So we have a big nerve, we have nerve fascicles, and then we have, these nerve fascicles are made up of nerve fibers, okay? So the nerve fiber, here, the very tiny, teeny nerve fiber is covered by the endoneurium, okay? Endo is usually in, so the most inner part of the nerve is covered by the endo. And then we have the perineurium. The perineurium is there to cover the nerve fascicle, as you can see, okay? So we have a fascicle, the nerve fascicle around that, and so on. Then we're going to have a bunch of fascicles that are going to form the nerve. So all these fascicles are joined together by the epineurium, okay, which is the very the one is the very outer surface covering. All right. Next, okay.
Do you mind if you recap real quick?
For this one?
Yeah, just real quick.
For everything?
Just like, لا بس the slide.
The other side. The other side is just that we have, okay, see, these are nerve fibers. These nerve fibers are covered by a covering. What is this covering? Endoneurium. These endoneurium, the nerve and the endoneurium is going to form a nerve fascicle, okay? Because we have think of it like this, okay? It's like a bunch of straws, okay? When you have a bunch of straws, okay? Each straw it has its own wrapper, okay? This wrapper of straw is the endoneurium. And then we have something that will hold all of the straws together, like a bag that holds all the straws together. This is the perineurium. And then if we have a bunch of different packets of straws that are covered already in everything, this is the epineurium. That's the very outer layer of the nerve. Okay? Perfect. Now we have injury. Okay, let's say we have, for whatever reason, the nerve is injured. Do you think nerves regenerate, yes or no?
No. Yes. Sometimes.
Depends on the
injury.
Exactly, depends. So first of all, when we have let's say this is our perfect nerve, okay, we have the body, the axon, and then we have the dendrites at the end. Let's say someone brought a knife and they cut it in half, alright? As you can see here. So what happens is there's going to be multiple things happening at the same time when we have damage to the nerve. First of all, let's go into the body. You can see the body. Usually, the body is wait, the next one is nicer. Okay. Usually, you can see how the healthy nerve looks like. So the body is filled with the nucleus and everything, and it looks nice. Once we have damage, once the axon is cut or we have any nerve damage, what happens is it's going to balloon up. Why is it ballooning up? What do you think, Yan? Because basically we have injury, and this injury we need to kind of try to work it up. We have to it's remember when if you have a problem in your life and you're stressed about it, you're going to think of so many solutions. So the axon is like the brain of the nerve, okay? So it's trying to think of so many solutions. So it's going to balloon up, right? And this is called chromatolysis. Why is it called chromatolysis? Because you can see the nucleus is going to displace, and we're going to have dispersion of Nissl substances. Okay, these Nissl substances are substances that are usually found inside the axon, alright, and they're waiting for a problem to happen for them to disperse and try to start acting up. Okay, and what happens in here is this ballooning up is kind of trying to increase protein formation to help like the axon to get over whatever injury happened. All right, and then we're going to have a proximal site of injury and a distal side of the injury, right? Now in the proximal side of injury, we're going to have what's called axonal retraction. In retraction, so the proximal side is still connected to the axon, to the brain of the nerve, okay? So because it's still connected, it has its nutrients, it has everything, so it's going to try to kind of help and try to grow, okay? So the proximal part is not going to be khalas, it's not going to fully die, alright? What happens is in the proximal part, we're going to have Wallerian degeneration. Now what does Wallerian degeneration mean? So you can see that the site is damaged. Once you cut off this, the proximal side is still connected to the axon, but the distal side is away from nutrients, away from everything, so it's just going to kind of like end itself. Alright, so we're going to have myelin, the myelin sheath is going to regress, everything is going to just, the microglia are going to come. Remember how we said microglia is there to protect the body? So once it sees that there's something abnormal there, like oh it's dead, it's going to take over and it's trying to kind of break it down and like kill it. Alright?
And then does the astrocyte come?
And then exactly. So after the microglia come and all of this happens, the astrocytes are going to come and we're going to have reactive gliosis. Okay? What is reactive gliosis? Basically, look, you see this myelin, the myelin, so it's going to kind of disintegrate because we're going to have a lot of like teeny tiny myelin sheets. These teeny tiny ones are going to stay. They're going to persist there. And why are they persisting there? They're trying to kind of cause a reactive gliosis. And what is a reactive gliosis? Reactive gliosis is basically they're going to get the astrocytes. They're going to call the astrocytes, which are basically the homekeepers. So the homekeepers are going to come and they're going to prevent regeneration of these damaged areas. Okay? So this is what Wallerian degeneration is. Is this clear? So in here, as you can see, in the proximal part, we're going to have something called sprouting. Sprouting means we're going to have teeny tiny axons that are going out and they're going to form. So why do we have this? This is a form of regeneration. And it only happens at the proximal end of injury. But at the distal end of injury, it's just going to suicide, alright? The homekeepers are going to like throw it away. Perfect. Okay. Now, the meninges, okay? I think we talked about, the meninges, right? So the meninges, yeah.
But the reactive gliosis is the same as myelin debris?
No, basically the myelin debris will stay there. Hello? It's going to persist. And this persistence is going to call the astrocytes. The reactive gliosis happens due to the astrocytes, okay? But the and we have, let's say, garbage, okay? We have garbage in there, and we need someone to clean it up. So if someone removes the garbage, it's not going to be cleaned up, it's already gone. But the garbage is going to persist, which is the myelin, the debris, and it is going to call the homekeeper. Who's the homekeeper? The astrocyte. So the astrocyte is going to come, and it's going to cause reactive gliosis, and it's going to sweep it away. Okay? You're welcome. Now for the meninges, we know that we have the brain, and then we have things that cover the brain, right? So what are the three layers of the meninges? Dura, arachnoid, and pia, right? So the one that's closest to the brain is the pia mater, and then we have the arachnoid, subarachnoid space between the pia mater and the arachnoid mater. Yeah, exactly, for the CS up to go all around, and then we have the arachnoid mater, and then we have the dura mater. Now the dura mater is the one that's the closest to the bone, alright? So between the dura and the bone, we have something called epidural space. Epi is usually over or above. So epidural is above the dura, so it's between the bone and the dura. And in here, usually you know when like someone falls on their head and they have like a bleeding there. So this is where sometimes the bleeding can accumulate. حتى بس ال air flowing space كمان sometimes bleeding can accumulate there. And if you can see, we have bridging veins. These bridging veins are usually the cause of accumulation of blood in the subaqueous space. And in the epidural space, we have the middle meningeal artery. Do you know the middle meningeal artery? So basically, if there's an injury to the middle meningeal artery, we're going to have an epidural, exactly, epidural hematoma, or like the, you know the difference between epidural and subdural, right?
Yes. I think it's subdural hemorrhage. It's the lemon-looking stuff, I remember.
The MMA is in the, basically the MMAs are in the epidural space,
That's
so
the
it's
bridge.
epidural,
That's
yeah.
the bridge, I think.
Yeah, the bridging is for the subdural. Anyways, now the blood-brain barrier. So what is the blood-brain barrier? So, subhanAllah, we're created in a way to protect our brain, okay? So we have a lot of vessels in the brain, and you know that. There's a bunch of vessels and a bunch of blood going there. So what we want to do is we're trying to protect our brain from everything that goes into our blood. Like if you think about we have a bunch of bacteria, viruses, whatever going through our circulation, and our body's trying to fight it. But the brain is not as strong as that, so we try to protect it before we need to, we try to prevent the infection before it happens. So how is this done? With the blood-brain barrier. Blood-brain barrier, it's made up of 4 things, okay? So, from the name, blood to brain. So we're going to start from the endothelium of the vessel. So I'm the vessel here, okay, and the brain is there. Okay, so we have four things in between us. The very first thing is the tight junctions of the endothelial cells, okay? So we have our endothelial cells. You know how usually the endothelium is fenestrated, okay? But in here we're going to have tight junctions that's going to close it together and prevent blood from going out, okay? So this is for the endothelium. And then we're going to have the basement membrane. So we have tight junctions that is closing the endothelium together, and then we have a basement membrane for these endothelial cells. So first of all, it's tight junctions, and then the endothelium. Then the third layer is the pericytes. Okay, you can see the pericytes. It's like hugging the basement membrane. It's just a cell there that hugs the membrane to keep it shut. So we have tight junctions, we have basement membrane, and then we have the pericytes. Last but not least, we have the astrocyte foot processes. So remember the astrocyte? The astrocyte had basically foot processes. So the astrocyte, you remember how does it look like? It's like a body and then it has foots. So the astrocyte is going to put its foot just to make sure khalas, you're not going to go in here. You have all these layers, but no, you're not going to come, okay? So we have tight junctions, basement membrane, pericyte, foot of astrocytes, okay? Now, what happens is, the blood-brain barrier protects us from so many different things, but we have some things that actually cross the blood-brain barrier, like the glucose, like the lipids and non-polar substances that we need. So non-polar substances and lipids, usually they just go via diffusion, okay? But for glucose and amino acids, proteins, they have their own carrier-mediated transport, so they have carriers that are going to carry them along the way, all right?
I just have a quick question.
Yes.
So the pericyte, it doesn't have a specific function. It's just there for support and
Honestly, I'm not 100% sure if it has another function. You can look into that, but the main function of it is it's part of the blood-brain barrier protecting the brain.
Yeah.
Okay. Next, so basically when an injury happens, let's say, do you know when someone goes into the hospital and they have their brain is swelling up, they have a lot of edema and they have things. So what do? If I have whatever injury that's causing a lot of water to basically retain in my head, usually they give them a medication. And this medication is a diuretic. Diuretic means it's something that lets the water go away, leave the body. So this diuretic, we have an example, mannitol. So mannitol is a drug that usually is given to people that have edema in their brain. We want to think of it, the head is a very tight structure. If we have edema, if we have water swelling up, what happens is the pressure is going to increase, and this is going to be more harmful than anything. So what you do, you try to relieve this. So how do we relieve it? By disrupting the blood-brain barrier. And how do we disrupt the blood-brain barrier? With the drug mannitol. It's going to cause extravasation of fluids. So we're going to have release of everything. Another thing that can cause dysfunction of the blood-brain barrier is vasogenic edema. Vasogenic edema usually, so it sounds like a big word, scary word, but vasogenic edema, if you look at it, what happens is, and we're going to have a disruption of the blood-brain barrier due to inflammation. So we're going to have a lot of inflammatory markers, oxidative stress, a lot of things are going to start activating the blood-brain barrier. And if you know inflammation, what is inflammation? Like the inflammatory markers usually increase permeability. Okay, so if we have inflammation and all of these things, they're going to disrupt the blood-brain barrier and we're going to have vasogenic edema. Okay? Is this clear?
Yes.
Yeah? I feel like there's...
There's a little bit uncertain.
Basically, it's just that if we have inflammation, or anything that's hard, okay, let's say you see, this is the astrocyte, this is the blood vessel. Remember how the astrocyte, the foot of the astrocyte is there to kind of seal everything. We have, let's say, an injury. We have inflammation, something that's causing it to be abnormal. So inflammation, I think you took this in POD. What does inflammation usually do? It increases the permeability of vessels. So if we have inflammation, we have tight junctions that are kind of closing up. But because of the inflammatory markers, the cytokines, all of these things, it's going to kind of still get fenestrated more, allow the things to leak. So these are the things that are going to allow the blood-brain barrier to be disrupted, allowing water and fluids and proteins and all of these things that were regulated to be irregulated and to just go and seep through. All right? And this thing is called vasogenic edema. Okay? And the swelling off of the brain because of all of the inflammation and everything. Now, another thing, this is the vasogenic edema. The drug that I was talking about, it's not specifically for, this vasogenic edema is caused by inflammation. We have edema can be caused by so many different things, like مثلا a hemorrhagic stroke can cause increased, so many things can cause the pressure in the brain to be really high. Alright? Yeah. Thank you so much. Okay. So basically, as you can see, mannitol is like a drug that disrupts the blood-brain barrier, allowing these fluids to leave. Okay, shukran. Okay. Is it clear? Just know that the blood-brain barrier is disrupted when inflammation causing vasogenic edema. Some drugs can disrupt the blood-brain barrier to decrease the pressure. Okay? Moving on, we have something called Chiari malformation. Are you guys familiar with Chiari malformation? Kind of? Okay. What is Chiari malformation? Chiari malformation is a congenital, usually it happens during, it's just the way congenital as the baby is born with it, okay? Chiari malformation, we have two different types. We have type 1 and type 2. The most common, the thing I think you guys take is type 1. So, you see how the brain is normal like that? Everything is there. You see how we have our beautiful cerebellum, cerebrum, the medulla. Nothing is going out. You see this foramen magnum? Remember the foramen magnum where the spinal cord eventually leaves? Nothing is going there but the spinal cord. Now, in Chiari malformation, what happens is you see the cerebellar. You see the cerebellum in here, it's normal. In here, the cerebellar tonsils are herniating. So they're leaving their place and they're going through the foramen magnum. Cerebellar tonsils are supposed to stay in the head, with the brain. But in Chiari malformation, subhanAllah, they're born with tonsils, okay, that are herniated, and you can see in here, this herniation, they're herniated down, so they're placed down, alright? And they can have something called syringomyelia, we're going to talk about it later on after we talked about the spinal cord. Is this clear? So Chiari malformation type 1, we're only going to have the idea as Chiari malformation type 1, tonsillar herniation, okay? So the tonsillar herniation, a tonsil of the cerebellum, we have the cerebellum in here, okay? So we're going to have displacement down. This is Chiari type 1, okay? What will this cause? In children, it can be asymptomatic, okay, in childhood. يعني this is something they grow up with. So when they're children, they might not have any symptoms, they might be asymptomatic, but as they grow old, they're going to have headaches, which makes sense because you remember how like you see how like مثلا usually CSF will flow normally هيك. هلا هون it's disrupted, so it's going to cause pressure and pain. So they're going to have headaches, and then they're going to have cerebellar signs. Okay? So they're going to have, because if you think of it, the tonsils that are herniating are part of the cerebellum, right? So they're going to have cerebellar signs. What are some cerebellar signs that you know? Ataxia?
Yeah.
Ataxia, dysmetria, dysbiokinesia, what else? Nystagmus. So all of these cerebellar signs can later on manifest as adults. Okay? This is Carey malformation type 1. Now type 2, okay? In type 2, what happens is it's more severe than Carey 1, okay? It's the same idea. We have displacement, okay? But what happens is it's not only the tonsils that are displaced, but rather the cerebellum, the brainstem, and the fourth ventricle. So all of them. It's kind of like the brain is just like pulled down, you know? Do you get me? So in Carey type 1, it's only the tonsils. In type 2, it's like everything is a kind of pulled straight at that, but it's going to be more severe. We're going to have basically, in type 1, they're asymptomatic in childhood, but in type 2, they're symptomatic. They're going to have dysphagia, which is difficulty swallowing, okay? They're going to have stridor, apnea, they're going to have weakness. Okay, do you know what stridor is? Stridor. Okay, so basically it's noisy breathing. So it's basically when they breathe, they make a noise because it's really hard for them to breathe, alright? So they're going to have stridor, they're going to have apnea. Apnea means shortness of breath, okay? Because if you all know, what is the brainstem? So the brainstem is the place where it basically kind of controls the breathing, it controls because of the vagus nerve, it controls dysphagia because of the different command vagus nerve has to do with the dysphagia and other, exactly. We have the limb weakness because of the cerebellum itself. All like you see the cerebellum, the brainstem, and the fourth ventricle. All of them are going down. Okay, so we're going to have these manifestations. Now we're going to the spinal cord. I think we have to take a break. So,
Can we?
yeah.
Would you guys like a break?
Can we like take
For
a break in
a few minutes, sure.
Like,
Just
sure.
10 minutes.
There's food on the way. Can we take a break in like 10 minutes?
Oh, we can take it in 10 minutes. Yeah, sure. Okay, perfect. خلاص. In 10 minutes we take a break. There's food on the way now.
Oh, almost?
Yeah.
Why? Since we're hungry.
I don't know. Anyways, so we're not going to go into the spinal cord itself. We'll just go into the basics. هلا أول شيء. You know the spinal cord. We have spinal nerves that are coming out of the spinal cord. Okay. So this is our spinal cord. We have it's basically engulfed by the vertebra. Okay, and the vertebra is the protective layer that protects it. So we have the cervical spine. We have the thoracic, lumbar, sacral, and coccygeal. So we have cervical nerves. So it makes sense that we would have cervical nerves, thoracic nerves, lumbar, and then we have the sacral. Okay? So how many nerves in total do we have? Perfect.
31.
31. Exactly. So we have 31 peripheral nerves. And these 31 peripheral nerves are made up of 8 cervical nerves. Okay? We have 12 thoracic nerves, 5 lumbar, and 5 sacral. Alright? So that's all you need to know. Basically the nerves, they're going to supply based on their position. So cervical nerves are going to probably give the upper body because it's in the neck. So you see there we have the head and neck, the diaphragm, deltoids, everything like upper body, okay? The neck and the upper body. And then once we go into the thoracic area, it's going to give the thoracic area, the chest muscles, abdominal muscles. Then we have the lumbar lumbar nerves. So the lumbar nerves is going to go all the way into the legs. L for lower, so our legs, L for legs, that's the lumbar. And then the sacral is usually has to do with like
The area of the sacrum.
Exactly. It has to do with يعني bowel movement. It has to do with going into the bathroom, urination. Yeah. So basically, we're going to have all of these things, and the spinal cord. We said it goes all the way down, right? But does it go all the way down into the to the coccygeal area or no? Like where does the spinal cord end?
L1, L2.
L1, L2. Okay, but why?
Adults.
What? In adults. Perfect. So basically the spinal cord is going to go all the way down to L1 and between L1 and L2. Then it's going to form the conus medullaris. What is the conus medullaris? It's just the end of the spinal cord, alright? And then from the conus medullaris, we're going to have like a bunch of nerves like going all the way down. Because, okay, it ends at L1, L2, but like we have, you know the dermatomes? We're going to talk about them right now. But yeah, you know how like we have L1, L2, and then we have all the digits up until like the sacral, like S1, S2, S3, S4, S5. So where are they if the cord ends there? So basically, it's the coda equina. So the nerves, like okay, the spinal cord ends at L1, L2, but then the nerves are going to go all the way down and then start to leave at the place where they're supposed to leave. All right?
We have also something called cornea absada, I think, something like that, which is basically, it looks like a horse tail.
Yeah, is this?
Cornea
equina.
And
Yeah,
there's
yes.
another cord which...
Conus medullaris.
Yes.
Okay, so this is the conus medullaris, it's the end of the spinal cord, and then we have the coda equina. All right. Now, why is it why is it clinically relevant that the spinal cord ends at L1 and L2?
Lumbar puncture.
Lumbar puncture, perfect. So basically, when we have meningitis, we have infection of the brain, we have increased pressure of the brain, what do we want to try to figure out? We want to take a CSF sample. And how do we take usually CSF sample? Through lumbar puncture, alright? So for the lumbar puncture, what is it called? Yeah, so usually it's advised to do between L3 and L5. Okay? I know that the spinal cord ends between L1 and L2. It's better to do it between L4 and L5 because there might be anatomic variations and you don't want to injure the patient. So L4 and L5 is the most safe area to aim for in lumbar puncture. And I'm pretty sure, have you tried lumbar puncture yet?
Not yet.
You will in pro.
Second year?
help you. No, second year. You're going to do lumbar puncture on the mannequin. And it's going to actually release fluids and everything. It's interesting. So basically for lumbar puncture, you see all of these layers that it goes through. That's really not important. Okay, so we said conus medullaris and coda equina. Right? So conus medullaris is the end of the spinal cord. Coda equina is all the nerves that are leaving after the spinal cord. So if we have damage to the coda equina or the conus medullaris, we're going to have their syndrome. So conus medullaris syndrome is just an injury to the conus medullaris, and coda equina syndrome is going to be damage to the coda equina. But what's going to be the difference between those two? If I injured the coda conus medullaris, what will the difference be between that and injuring the coda equina?
Oh, the conus medullaris would be upper motor neuron because it's the actual spinal cord
Tamam.
rather than just the nerves.
Okay, interesting, and you're right. So basically what happens usually when we have an injury to the conus medullaris or the coda equina, wherever the injury is at, okay, so in conus medullaris it's going to probably be at L1, L2, the end of the spinal cord, alright? So how will it usually manifest? It will manifest with radicular low back pain. So because the spinal cord is at the end of the back, so you're going to have back pain, right? You're going to have, we said that the lumbar part is for the legs, so you're going to have lower limb weakness, okay? What's your question?
What does radicular means?
Radicular means, I think it means it radiates. So it's basically pain in the back that radiates into your feet, alright? You get me? Into your lower back. Okay, what happened? Anyways, wait. Okay. So it's going to radiate into the back. Hello. We're going to have saddle anesthesia. Do you guys know what saddle anesthesia might mean? Just guess. So basically, we're saying in our damage.
In the region where you sit on a horse, everything there is numb.
Exactly, that's perfect. So basically.
So the inner thigh, basically also. نفسه ولا؟
يعني everything at the back, يعني the lower back, the buttocks region, the upper thighs from the back, everything, all of the area where you used to sit is going to be no. Okay? What else? We're going to have bladder and bowel dysfunction because we said at that area we have when we said the sacral region is going to basically be in control of all of the. You need to think of it because once you cut the spinal cord, wait, use this. Okay. So I cut the spinal cord right here. So everything below does not have innervation. You get me? So that's why we're going to have this back pain, this anesthesia. We're going to have bladder and bowel dysfunction. They're not going to be able to control their bladder. They're not going to be able to control their bowel movements. And they're going to have lower limb weakness. Okay? As your colleague mentioned, the difference between conus medullaris and cauda equina is that in conus medullaris you're going to have upper motor neuron signs. And do you know what are the upper motor neuron signs? Like we know we have weakness.
Spastic paralysis.
Spastic, exactly. So in upper motor neuron lesions, where the lower limb is going to become spastic. All right. And we're going to have hyperreflexia. Perfect. So it's going to be spastic. We're going to have hyperreflexia. Yes.
Is this the conus medullaris or cardio?
No, the conus medullaris, because we're injuring the spinal cord itself. All right. Now the cauda equina, on the other hand, it's going to have lower motor neuron lesions. All right. So it's going to be flaccid paralysis. We're going to have hyporeflexia. All right.
So it's like bulk. I think in POD we took a disease where basically if you catch a bacteria, eat a bacteria, this is gonna lead to like very sloppy baby. Is it?
It's what is the bacteria?
Polio.
Yeah. Something like
Yeah, we're going to talk about the polio later.
Polio أو botulism أو يعني.
حتى GBS can cause that.
Flaccidness is lower motor neuron basically.
Yeah. So this is just like a table to differentiate between upper and lower motor. We're going to take a break after this class because this is the last part before the spinal cord. So we have upper motor neuron lesions and lower motor neuron. Okay. So the difference is that, as we said, the paralysis in upper motor neuron. First of all, more than one thing is going to be paralyzed. Okay, and it's going to be spastic. All right. We're going to have spastic and it's going to be rigid. While in lower motor neuron lesions, the motor neuron itself is going to damage whatever if a motor neuron is damaged, whatever it supplies is going to be weak, not multiple things, all right? The deep tendon reflexes, the reflexes are basically hypo and hyperreflexia. So for spastic, it's going for upper motor neuron, it's going to be hyperreflexic, hyperreflexia or exaggerated, and lower motor neuron is going to be absent or hyporeflexia. The rest are not. Oh, okay. Fasciculations and fibrillations. All right. Do you know what fasciculations are?
basically shaking.
Yeah, like it's basically so when the muscle is like kind of twitching. So these are fasciculations. All right. So twitching of muscles. This usually happens in lower motor neuron. I just want you to don't differentiate don't confuse spastic with fasciculations. Okay. Spastic is the limb itself is going to be rigid. They're not going to be able to hang it. It's going to be like tense and contracted. Exactly. Fasciculations are teeny tiny, like contractions, relaxations. So keep that in mind. Don't confuse fasciculations for spasticity. Come on.
So plantar response important.
Yeah. So for the plantar response, do you know the Babinski? So can someone explain what the Babinski is, or how do we do it?
We basically jerk on the lateral side, and it should basically dorsiflex.
Okay. So basically, we have the foot. Hello. So on the plantar side of the foot, okay, what we do is Okay. So what we do is this is the plantar side of the foot. Usually we get like something and we try to like draw. Okay. So what happens is usually when you do this on a healthy patient, nothing will happen. Okay, maybe he will move his feet because it's ticklish or something, but nothing will happen. But when we have an upper motor neuron, we're going to have a positive Babinski sign. And a Babinski sign, what happens is when you try to like go all the way to the sole of the foot, the big toe is going to fly out lawara. Okay, so this is the leg. I'm going to get my whatever and like do this. So it will fan out lawara. All right. It's going to be really clear because it's going to fan and it's going to go all the way back, you know. But it's not any, because some people are ticklish, it's going to show انه مثلا they're moving their fingers, but I know it's like a primitive reflex. And what I mean by primitive reflex, it's a reflex that we have when we were babies. So Babinski reflex is a reflex that we had when we were young. Like by the age of like 1 year we lost it, okay? But if you have an upper motor neuron lesion, that's what will happen. You're going to do that and then it's going to fan out, like, okay? So that's important. That's it for now. Are you excited, guys? To the tracts?
Very long.
So, what is your understanding of a spinal tract?
There's sensory, there's
Okay, we have motor, we have sensory tracts. Hello? Hello. Spinal tracts, okay, we were talking about the spinal cord, we talked about peripheral nerves, we talked about all of these bits and pieces, alright? Now, spinal tracts are basically, so we said, we have, okay, remember the nerves that we talked about at the very beginning, the free nerve endings that check pain and pressure, okay? طيب, they detect the pain and pressure, but where does it go? Where does it relay? So this is what a tract is. It's like a railway, okay? It's like a paved way that is really fast for specific things. تمام? We're going to start with the spinothalamic tract. Spinothalamic. So it has to do with the spinal cord and it has to do with the thalamus, alright? Now spinothalamic, what is the main thing for it? Pain and temperature. Hello? فالidea is إنه نحن we have, is my voice clear or do I need the microphone?
I think you use like because it's recorded.
Oh, it's recorded, true. Okay, so again, a tract, it's just a railway. A railway that is always, you know how مثلا you know how we're exporting goods? So you know how they get like this big trains where they export goods or this height? They have a specific route to take and they always take it and they just take it, حتى the people who drive the car, they take it without even thinking. So this is what a spinal tract is. It's going to relay information about a specific thing without even thinking. Hello? So, spinothalamic tract is going to involve the, it's going to involve the spinal cord and the thalamus in the brain, and then eventually the sensory region of the brain, alright? So spinothalamic is important for pain and temperature, okay? Let's say you have someone who is putting their hands somewhere, and I put my hand by mistake on an oven, okay? And I did not know it's on. So I got burnt, right? So this reflex of removing my arm because it's hot comes from the spinothalamic tract. Hello? So how does it start? First of all, in here, okay, let's go all the way from down up. I know it's going like first, second, third, but let's do the opposite, and it's the same thing. Hello? Let's say, as I said, the same example, I put my hand on an oven, it's hot. I put my hand on a hot thing. What happens is, the free nerve endings in here, they're going to sense the temperature. And they're going to go all the way back through the dorsal root ganglion. This is the dorsal root ganglion, right? So it's going to go all the way back in the posterior horn, and then it's going to go into the horn in here, okay? The posterior horn. Hello? Now, this nerve is the third, this is basically the first one, the sensory nerve ending. So the sensory nerve ending that we talked about, this is the first nerve. It's going to synapse with the other nerve that is, it's going to synapse with the other nerve that's already there in the posterior horn. So, is this clear up until now? So we have pain or something hot. The nerve endings are going to pick it up and they're going to go run to the spinal cord because this is the closest thing to that. Okay? They ran to the spinal cord, they went through the dorsal, the dorsal root ganglion into the posterior horn. In here, we have a nerve that's waiting for it. Okay? Let's think of it like a traffic light. We said it's a route. This is a traffic light. There, at this traffic light, it's going to give its signal to the other person. Or like a point of, you know how you order something and then the person has to give it to you? So this is the point, it's a checkpoint where it's going to relay the information. So okay, I had pain, I had temperature, take it to the brain, okay? Because that's what spinal cord will do. It will take the information all the way back to the brain. So what happens is, in here, this is طبعا on the side of the lesion, okay? This is the side of the lesion. Let's say this is the right side. Yeah, this is the right side, okay? So what happens is, the second neuron, okay, not the first one that got the thing, the one that we gave the thing to, it's going to be like, you know what, I don't feel like going up directly, let me go around. So it's going to decassate, alright? So I am at the right side, I gave my thing at the right side, but let's say the way from the right side is blocked, or there's like traffic or whatever. So what will it do? It will go decassate into the other right, into the other side, the contralateral side, alright? And then go up. Tamam? Where does this decassation happen?
At the level of the
Spinal cord. At the level of the lesion. Hello? So again, we have in here pain and temperature. We have pain and temperature, and this is this. I am the free nerve endings. I detect the pain and temperature. I go and I reach this checkpoint. This checkpoint, where is it? It's in the dorsal, it's at the dorsal root ganglion, at the posterior horn specifically. It's at the posterior horn, at the spinal cord, at the lesion, the site of the lesion, yani, the same area, alright? Do you get what I mean when I say same area? And I can't know the specific area, but like this nerve, okay, let's say the nerve that goes to my hand, it goes into the spinal cord that's literally here, okay? So I mean at that site.
So it decassates as soon as it enters the spinal cord.
Yeah, and once it gives off the information, so the first one, which is the free nerve ending, is like خلاص, I got it to the spinal cord, that's my job. Once I gave it to the second neuron, alright, that the one that's gonna go up, the second neuron is like, it's faster if I just go to the other side and take an elevator up, alright? So it's gonna go it will decassate at the same level at the spinal cord, and then it's going to go all the way up into the thalamus, alright? And it's called spinothalamic tract, okay? So from the spinal cord all the way to the thalamus. At the thalamus, I'm pretty sure you're going to take this lecture later on. The thalamus is basically a very important organ, like extremely important, because everything relates there. Every single thing. Motor, sensory, everything relates there, okay? Just think, it's the headquarters. You know, مثلا NASA, like the space missions and everything. So you know how NASA is the headquarters and they like give information like, oh, do this, do that, whatever. So the thalamus is that, okay? Everything relays there and then goes to its destination. You can also think of it as an airport. It goes there and then eventually goes to like a transit area. Hello? So it will go to the thalamus, and then once it goes into the thalamus, this is where the second neuron ends, okay? So our first neuron was the free nerve ending. The free nerve ending gave it to the second one, which was within the spinal tract, or the spinal cord, yani. The second neuron decassated at the level of the spinal cord and went all the way up into the thalamus, and then it was like, khalas, I went a long way. It gives the job to the third one, okay? The third one is going to take the information from the thalamus all the way to the somatosensory, because again, pain and temperature is sensory. Hello? Is it clear? So, this is how the information is going to go. For the most important part of the spinothalamic tract is the idea that the information is going to decassate at the level of the lesion, okay? So it's going to go to the contralateral side. Yani, why is this important? Let's say I had an injury. Hello? I had an injury here. The free nerve endings are gone. What would be gone? Pain and temperature where? Ipsilateral side. Perfect. تمام. Let's say أنا كان عندي a lesion مثلا someone came and he did a knife lesion. Okay, like I struck someone in their back with a knife, but I struck them on their left side. Okay? So I struck them at the left side here. What would be gone? Contralateral pain and temperature. This is the idea. Okay? At the spinal cord level. Anything above that level, if it's injured, okay? مثلا anything in here, if it's injured, then it's going to cause an issue in here. But مثلا we have another one here. If the other one is injured, then the contralateral side is injured, okay? At the site of the lesion itself, ipsilateral. Tamam? Clear? This is the spinal thalamic tract. Do you have any questions about it?
No.
Clear? يعني هلا if I ask a question you know it? Sure. Yeah. So we finished the spinal thalamic. Now we have the dorsal column. Okay, spinal thalamic and pain and temperature. Dorsal column is everything else. Okay? Dorsal column has another name. Does anyone know the other name?
Medial meniscus.
Yeah, is it actually? Yeah, it is. The dorsal column is called the medial meniscus because you can see. Why is it called the medial meniscus? Because I think it decussates at the medial meniscus. You get me?
Is it also because it's also in the middle of the medulla? That's why it's also.
It might be, I don't know. But it's easier to remember. It's called medial meniscus because that's where the decussation happens. Okay? Anyways, let's go again into the same scenario. So, pain, pressure, not pain, sorry. Don't do that mistake. Pressure, touch, and proprioception. What is proprioception? Does anyone know what proprioception is?
Basically, when you're. Do you guys want to say it?
No, it's okay.
Okay, so basically, when you're in space and you end up covered, like you close your eyes and you know where you are in the space. Basically.
Okay, so proprioception, and what you said is correct. But okay, هلا نحن proprioception, the idea of proprioception is it's like, you know, we have multiple joints in our body, alright? So it's like nerves that detect the position of your joints and the position of yourself. So we have a specific test that will help us know if the proprioception is impaired. Do you know the name of the test, the clinical test?
Wait, what?
The test that helps to know if the proprioception is gone or not, the clinical test.
Was it something like
Is it
this?
nose to
No, that's the material.
Is it this one? Remember where they
What do you mean by this one?
you asked them to close their eyes?
And this is called pronator drift. It's a pronator drift. This is one of them. Another one is the Romberg. Do you remember the Romberg? So Romberg has to do. So basically, what is the Romberg test? The Romberg test is you just ask the patient close your eyes.
Heel to toe.
Heel to toe. Heel to toe is for. It's not for proprioception. It's for dysmetria. Come on.
Oh,
Okay. But in the lower, like upper is this, and then this material تحت. Okay. Romberg test. What is the Romberg test? So Romberg test, the patient we ask the patient to close your eyes, put your hands out, and then you would ask him to just stand. If their proprioception is gone, they're going to sway around, or they're going to lose balance. They're going to fall. All right. So this is something that we use كمان. With pronator drift كمان is another test where you ask them to close their eyes, extend their arms, they turn their eyes off, they shut their eyes, and then it starts to go away. Okay? طيب, for proprioception, we know now what proprioception is. Okay? So it's kind of just knowing where you are in space. So what happens is we have. Do you guys remember what are the sensory receptors that detect proprioception and pressure? We talked about them earlier today. Wait. What did you say?
She said Merkel. She said.
Merkel. Yes, the Merkel disc. Remember the Merkel disc? It detects the pressure. What other thing?
And there's the one that starts with P. Compass.
Pacinian corpuscle. Okay, so those two. This is where we start. Okay? So this is where we are at the peripheries. Okay? We have these. They're detecting pressure. They're detecting proprioception. Whatever. Okay? So they detect all of these things. And let's say there is a positive finding for whatever, or they just want to tell the brain like, oh, I see pressure, or I don't see pressure, or whatever. But what happens is, on the same side of the lesion, okay, the first neuron, okay, is gonna go up the dorsal root, all the way up. It's not gonna meet anything in the spinal cord. It's just gonna be like, you know what? I'm not gonna bother. It runs all the way up into the medulla. Hello? So it's going to take the highway to the medulla, and then at the medulla, it's like, oh, I went a very long way. خلاص, I'm done. Let me give it to the next person, which is the second synapse, or the second neuron. So it's going to synapse with the second neuron. Now the second neuron is going to be at the same place because you have to know, like, okay, this nerve is okay. It's like I'm not gonna bother at the spinal cord. I'm just gonna go directly to the source. But at the same time, it's lazy, so it's just gonna give it to the person at the same place. So it's not gonna decussate. Okay? So I'm on the right side. It's going to stay on the right side. Give it to the next neuron. Here you go. This is the information. There's a lot of pressure on me, and it's like, you know, class, so much pressure. I just take it, you know. So she gives it to the medulla. In the medulla, what happens is the second neuron, okay, she takes the information, she's like, oh my god, that's a lot of pressure. I don't think I'm able to take it from here all the way up, so we'll go to the other side. So the decussation is going to happen in the medulla, at the medial meniscus, at the second nerve. So the second nerve is going to be like, it's a lot of pressure on me, I can't go there. Let me go to the other side, maybe relax a bit and then go up. Hello? But it decussates into the left side, and that's where it goes up. Where? In the medulla. Hello? So keep it in mind. Medulla. Tamam? So again, spinal thalamic, where did the decussation happen? Spinal cord at the site of the lesion. Dorsal column, it's going to be in the medulla at the medial meniscus. Okay? That's where the decussation happens. Yeah.
Doctor, so for like the word that you were saying, okay, it's the second neuron in both the spinal thalamic,
in the first one? Oh, actually, yeah, it was the second neuron in both.
Yeah,
Yeah, it is. Wait, let me check.
It is,
Yeah.
So
it's
they're
the
both
they're both. The second neuron is the one that's like, you know what, it's too much, let me go into the other side. Hello? So it decussates, goes into the other side, and goes all the way to the thalamus. Because again, we said the thalamus is our airport. Okay? So it goes into the thalamus and then the somatosensory. So the most important, guys, in these specific ones is the first and second neuron. The third one is it's going to end up in the somatosensory part of the brain. Do you know where the somatosensory part of the brain is?
yes.
Yep. The postcentral gyrus is the sensory part, and the homunculus part will go to wherever the homunculus is. You remember the homunculus?
Scared.
Yeah. So this is everything for dorsal column. Yalla, here. Where does it decussate? Medulla. Perfect. Where does the spinal thalamic decussate? Spinal cord. That's all you need to know. What are we detecting in dorsal column?
Pressure, vibration, fine touch, and
Proprioception. Perfect. So spinal thalamic is pain and temperature. Everything else dorsal column. Okay. Everything clear?
yes.
Okay, perfect. So let's go to the next one. Okay, wait. I don't know why it's like. Okay. Now corticospinal tract. You can see the thing I put that's for movement. Okay? So the corticospinal. And I want you to focus on the word corticospinal. So cortex and spinal cord. Because if I want to move something, I have to think of it and then it has to go. صح؟ هلا هونيك بالsensory it was spinal thalamic or spinal whatever, you know? So the word, yeah, the name of the tract can give you an idea of where does it start or where does it go. And give you an idea of what it is. Corticospinal, it starts from the cortex, goes into the spinal cord. It's because it's motor. It's because if I want to move here, I think of it and then I do it, right? But in pain, temperature, pressure, proprioception, you feel it and then you move. Okay? تمام. فهلا corticospinal, it will start from the primary motor cortex. Yalla, where's the primary motor cortex?
It's
Precentral gyrus. Perfect. Precentral gyrus.
Just
And then
fourth Boltzmann area, I guess. Fourth.
Sure.
It was like it was labeled fourth Boltzmann area. Fourth.
Fourth, yeah, the Broman's area, yeah. I'm not sure, so I'll have to remember it because I didn't go over that part. Anyways, but I'm pretty sure it's correct. But now let's go into the corticospinal. حلو؟ فإحنا بلشنا من البرين. أنا on the right side, I want to move my left arm. طيب? What will happen if I want to move my left arm? the right side of my brain is going to fire information. So it will be like, tada, move your hand. So it's going to go from the primary cortex all the way to where? The medulla, okay? Why the medulla specifically? Because medulla is كمان يعني I think this is the second one. This is the second tract where it goes in the medulla, because medulla is kind of like the thalamus, the idea of it's an airport, you know, because if you think of it, it's the last part of the spinal cord. This is the medulla, not the spinal cord. But since it's the last part of the spinal cord, everything is gonna eventually have to go through it. Okay, so from my right side of the brain, it's gonna go to the right medulla. Okay, and then it's going to realize, you know, because the medulla is an airport, or it's like a place where everything goes. It's so crammed. I can't go, if I go on the right side, it's so cramped, I'm not going to get there. So it's going to decussate.
The first neuron.
The first
Yeah,
neuron.
without another synapse.
Yep. It's going to decussate itself. Because listen, motor neurons are like, you know, like strong, independent women. Like, I want to do this myself, I don't want anyone's help. Okay? That's how they are. Because I'm going to move something. I'm not going to wait for anyone to help me. So what will it do? It will go all the way from the primary motor cortex, okay, all the way to the medulla, the same side, and then it's going to see that it's crowded. It's going to decussate into the left side, and that's where it will go down all the way to the, where does it usually go? Where's the motor in the spinal cord?
Anterior horn.
Anterior horn. So as you can see in here, it will go all the way to the anterior horn, and then enter the, basically the anterior side of the pyramid, and then it will synapse with the, basically, lower motor neuron. Hello? Now, this is why we talk about upper motor neuron and lower motor neuron. That's where it comes back in place. Upper motor neuron is the big boss. It's going to, you see أصلاً شفتوها, it went all the way down into the point where, into the peripheral nerve. It landed peripheral nerve, and she's like, okay, now you do your job, alright? So that's why anywhere we have, like if I have damage here or here, okay? Okay, now that's an interesting question. If I have damage, if I have damage to the cerebrum itself, let's say someone came and like, with a knife, على the cerebrum itself, what would be affected?
Contralateral.
Contralateral, hello. But what if I damaged the medulla, the upper side of the medulla?
Contralateral.
But what if I did it at the horn itself, anterior horn?
Apsilateral.
Apsilateral. Keep that in mind. Okay?
حتى بالlower medulla apsilateral, right?
Up until the pyramidal decussation. Because you know how the pyramid, so basically I'm pretty sure tomorrow you're going to go through the cross sections of the medulla. But the cross sections, we have the decussation of the corticospinal is inside the pyramidal decussation, which is at the lower part of the medulla. Okay? Also on the cross section, you're going to see like an X, where you know that this is the pyramidal decussation. Anything before that is going to be contralateral. Anything after it is going to be apsilateral. Hello?
So in the corticospinal tract, basically the pyramids of the medulla, they're gonna be there.
The pyramids of what?
I remember, like when I was studying for the PAL, okay. I remember they mentioned in the pyramids of the medulla there is corticospinal tract. So if you damage the pyramids, you're gonna damage the corticospinal tract.
Yeah, because
So
it decussates inside the pyramids.
Uh-huh.
Decussation happens in the pyramids. All right?
Okay.
Come on. Did you get the point?
So is it contralateral or ipsilateral?
هلا عند decussation it's going to be contralateral. Everything after the decussation, like حتى basically if you cut it before the decussation, if it's like right here where it starts decussating, it's contralateral. Once it goes after the pyramidal decussation, it's ipsilateral. حلو؟ طيب وبعدين it will go into the lower motor neuron اللي هو النeuron that supplies this specific muscle. Okay? Again, what were the differences between upper motor neuron lesion and lower motor neuron lesion? Anyone? You already told me.
Paralysis.
spastic in the upper motor neuron,
Okay.
flaccid in the lower motor neuron.
Okay.
The upper motor neuron, we're gonna have hyperreflexia.
Okay.
While in the lower motor neuron, we're gonna have no reflexes.
Hyporeflexia. Okay. Perfect. And the Babinski reflex, where will it be positive? Upper motor neuron lesion. Perfect. Is there anything else with upper motor neuron? Let's see, we have the next one. Yeah, that's it. Fasciculations, where are they?
Lower.
Lower motor neuron. Perfect. طيب هلا we're going to talk about cases, okay? I want someone to read the case. تفضل.
You want me to cross? I think there's another one.
Yeah, perfect. Or you know, I can talk through this mic, or it doesn't.
This mic
work.
works.
Class, okay, give it to her. I can do it last. Does it work?
Yeah, I don't think it's a yeah.
Yeah.
A 6-year-old boy from a rural area presents to the clinic with fever, headache, and neck stiffness for the past 3 days. His parents report that he recently developed weakness in his right leg, which has progressively worsened. On examination, the child has flaccid paralysis with absent deep tendon reflexes in the affected leg, but sensation is intact. His history reveals no recent vaccinations, and his family relies on untreated well water. Further examination raises concern for respiratory muscle involvement, and he's admitted for monitoring.
I'm not gonna ask you what is this because it's written, but so we're going to cover now the spinal cord lesions. Hello? I wrote them as cases because this is what you get in the exam. طيب? وهلا we'll focus on the important things for case. So it started with fever, headache, neck stiffness for the past 3 days. What does that mean? Fever, headache. We have a problem in the brain. Infection. Perfect. Infection. يعني إنه the meninges are irritated, whatever. حلو? So keep that in mind. Infection. Plus, he has weakness in his right leg, okay? Which progressively worsened. So he had weakness, which is becoming worse in the leg. Hello? They did examination. It was flaccid paralysis. Flaccid paralysis means lower motor neuron lesion. Hello. Lower motor neuron. Absent deep tendon reflexes means lower motor neuron. Okay. They mentioned that there's no vaccinations, and he drank untreated well water. Why is this important? Because polio is basically something you can protect yourself from through vaccinations, and it's a fecal oral route of transmission. I think you took it in micro. Are you taking micro? No.
Yes, we did.
But you will. Yeah, you will.
Also, the age kind of gives.
The age. He's a child. Perfect. This is an amazing thing to point out. تمام. هلا. We said إنه it's lower motor neuron. We said it's the right leg. We said okay, lower motor neuron. Where are the lower motor neurons usually found?
Anterior horn.
Anterior horn. Perfect. And is it in both legs or only in one leg?
In both.
In one leg only, right leg. So it's asymmetrical. So if you have a patient that's young, asymmetrical weakness with lower motor neuron size, you think of poliomyelitis. And you can see it in here because this is which side? This is the right side.
So it's
Okay?
right fusion as
And it's
well.
a right leg. And it's a lower motor neuron. Usually the region at the motor neuron is ipsilateral, right? So ipsilateral region of the lower motor neuron. I know in here it's showing, but there is a small one, but the big and small shows it's asymmetrical. Okay? So again, if you have asymmetrical lesion, asymmetrical weakness, lower motor neuron, flaccid, blah 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 blah. Where is the situation? Where is it injured at the spinal cord? At ipsilateral anterior horn. Clear?
Is the tract that is being affected the cortical spinal tract?
Yeah. Why? Because it's movement. Weakness is movement.
Yeah.
Okay. They did not say. Is there a question?
No, after you're done, sorry.
Yeah, sure. Weakness means there's problem with movement. If there was paresthesia, or if there was, they're going to say loss of sensation, then that's the other tract.
What do you mean bigger lesion?
Oh, you see how the circle is واحدة كبيرة والثانية صغيرة? That's what they mean. They mean like, no, it's asymmetric. Yani it can involve the right leg, but not the left leg. It can involve the right leg and a little bit of the upper arm. You know, like it's asymmetrical and it's not in the same place. Hello? So this is our first case. Is it clear? Yani again, if we get a boy that's young, okay, young, ipsilateral, lower motor neuron lesion, in whatever parts of the body, then we think of polymyelitis. Hello? Perfect. Next. Oh, yeah, let's talk about polymyelitis just like a really, really fast. So it's just basically a viral infection. It goes into the neuron, it kills the neuron. We're going to have irreversible paralysis. Well, if you see in here, they said that he was admitted for monitoring and there was concerns for respiratory muscle involvement. Why is polio scary? Polio is scary because it can eventually affect the diaphragm. We're going to have diaphragm paralysis, death. Because once the diaphragm is not working, they die. Yes?
Irreversible as in even after we diagnose it, we cannot treat it?
We can treat the polio, but the paralysis would need it's not, once you treat the polio, okay, it's gone. But like the paralysis is gonna be, like, there are going to be remnants of the paralysis, so he has to go through physiotherapy and a lot of things, you know, to gain function, but there's no, I don't know what's the prognosis on full like function back, but you get what I mean, like irreversible damage. You get me?
Tanya.
Yeah.
Very basic question.
Why?
I do.
Oh,
Sorry.
Yes.
When we say lesion, what do we mean exactly? Like, is it like
Basically injury, whether it's infection, it's in this case poliomyelitis, the lesion is an injury, عندنا inflammation and damage to this place. It's a damage, the place where we have damage. فهمتي علي؟
when we say irreversible, would we consider this like a very severe lesion where the nerve is?
Nerve is not going to be back. You get me? Okay, I don't know the specifics of if it's going to be able to regenerate or not. But we know spinal cord does not regenerate. The only thing that regenerates is the peripheral nerves.
Okay.
Or the neurons itself. But the spinal cord itself, if it's like a heavy section of the brown sacroid syndrome that we're going to talk later on, it's not going to be reversible. Once it's cut, you can't, there's no surgery, there's nothing that can ما حيرجع spinal cord back like normal. Do you get me? But that's what we mean by irreversible.
So, like, do we need to know the mechanism behind why there is paralysis? Like, what happens to the neurons? Does it get like demyelinated or stuff like that?
Unless this is like, okay, unless you're taking demyelinating diseases. For now, spinal cord lesions, just know lesion and to identify what tract or whatever is going on. That's it.
That's it.
But later on, you're going to take demyelinating diseases. That's something else.
Pathology.
Yeah, and pathology. Okay, next. Okay. Who wants to read this case?
If someone else doesn't want
Yellow. Give her the mic.
I can scream.
Okay.
A 3-month-old infant is brought to the pediatric clinic due to severe muscle weakness. The parents report that the baby...
No. Parents report that the baby has been floppy since birth and struggles to lift their head. They also notice minimal spontaneous movements and occasional tongue twitching. On examination, the baby exhibits severe hypotonia, symmetric weakness, more in proximal muscles, absent deep tongue tendon reflex, and tongue fasciculations. The parents mentioned to a family history of early infantile muscle weakness, raising suspicion of a genetic condition.
Okay. So what's the difference between this case and the other case? Symmetrical. Okay, so we have symmetrical lower motor neuron lesion. Okay, and there is family history. So what do you think of? You think of spinal muscular atrophy. Okay, and if you see, Aslan, the baby was born floppy, and this is very, very pathognomic or very specific to SMA, which is the spinal muscular atrophy. Okay, so in spinal muscular atrophy, if you look at the lesions in here, let's compare. Here, it was asymmetric, and we have it's in the anterior horn because it's a muscle, it's weakness, it's motor. Okay, so the anterior horn is affected. Here, we have different sizes of the lesion because it's asymmetrical. That's what they're trying to show you. Tamam. But in here, they're symmetrical. Okay, so we're going to have symmetrical weakness. okay? It's going to be lower motor neuron, floppy, fasciculations, atrophy. All of these are signs of lower motor neuron. And the genetic history or the patient's parents suggesting that, oh, there was someone in the family that had something similar, directly think of SMA, because SMA, again, is a genetic disorder. All right? Clear? Easy? Perfect.
Do we need to know the tracts that is affected, or just?
It's corticospinal. Yeah. So SMA, just a very quick recap. It's basically a mutation in the SMN1 gene. Blah blah blah. You don't need to know that. All you need to know. All you need to know is the motor neurons in the anterior horns are going to be affected bilaterally and symmetrically, and this is why we're going to have a floppy baby, alright? Or like the lesions are going to be flaccid, atrophy. They're not going to be. By the way, SMA patients later on you're going to take this. There's different types. Some types they can't even sit. Sometimes they can walk, but they can't. No. There's a very there's I think 4 types. But this is extra information. I'm just like telling you clinical information. So there's 4 different types. So one of them can't sit. One of them can't sit but can't stand. One of them can't stand but can, So it's mainly in the lower body, and sometimes it's just like weakness, and sometimes they can't even. They're going to have to be paraplegic, not diplegic for the rest of their life. We're going to finish by 4. Fine, you can pray after if you don't mind. Come on. SMA is clear? Yalla, next question. Who wants to? I want someone to play back. See video. It's me.
Mr. Ahmed.
It's not on.
Does it work?
Oh, it's working, I think.
Yeah, sure. Mr. Ahmed, a 55-year-old man, presents with progressive weakness over 6 months, starting in his right hand and spreading to his left hand. He also experiences muscle twitching, difficulty swallowing, slurred speech, and episodes of uncontrollable laughter and crying, pseudobulbar palsy. On examination, he has muscle atrophy and fasciculations in his upper limbs, spasticity and hyperreflexia in his lower limbs, and tongue atrophy with fasciculations. Sensation, bowel, and bladder function remain intact.
Okay, so we have a lot of things to cover in this case. So, let's point them out one by one. Oh, and the age. He's old, okay? The other 2 cases, they were young, they were relatively young, okay? One of them was really young and the other was like a bit older, but they're young. He has progressive weakness, and when we say progressive weakness, it means it's getting worse. So one day he woke up, he started feeling like, oh, my leg is not, and it kept getting worse, okay? It started in his right hand, okay? So we started in the right hand, and then it spread all the way to the left hand, okay? And this is the weakness. And then he also has muscle twitching, okay? Difficulty swallowing, which is dysphagia. He has slurred speech, which is dysarthria, okay? And episodes of uncontrollable laughter and crying, okay? And then when we examined him, we found that there was muscle atrophy and fasciculations. Muscle atrophy and fasciculation, what does that mean? Lower motor neuron in his upper limbs. But then when we went to the lower, it was spastic and hyperreflexic. So what does that mean? Upper motor neuron. And then we have tongue atrophy and fasciculations. Come on, this is more of like lower motor neuron, right? So we have dysphagia, dysarthria. We have lower motor neuron lesions in the upper motor neuron lesion in the lower. So we have a mixed thing. It's all over the place. When you see something that's mixed, first thing you think of is ALS. Okay? Amyotrophic lateral sclerosis. And from the name, we know that it's OSG on both sides, okay? It's symmetrical, okay? And because we have upper motor and lower motor neuron, it's gonna affect the anterior horn and the actual, The tract itself. Remember how we said that how did the corticospinal tract come? It came all the way, let's go back. It came all the way from the brain, صح? It went all the way down into the anterior horn, and then it went inside, right? So it's in here, where's the microphone? Okay, so basically it went all the way down into the spinal cord and then went into the anterior horn. So if you look in here, you see this area where it relays and then goes into the anterior horn. This is the place where it was affected in the ALS. Okay, and because it's affecting the I'll tell you why it's upper motor and lower motor neuron. Because basically it's affecting this point and this point, and this point in here. It's still like it affects all the way here. Hello, and this is the first. The upper motor neuron is this is the first nerve, right? The first. Yeah, it's called the first nerve. So this is the first nerve. So here we said the first nerve, it's always upper motor neuron. Alright? And then it synapses with the second one. Sorry. It synapses with the second one in the anterior horn, then we have the second nerve. So if you look at so basically in here it's the first, and then in here it's the second, right? If you look at the lesion that corresponds to the ALS, we have it in both. We have it here and there. Hello? But we're going to have upper motor neuron and lower motor neuron. Okay? Is it clear? So if we have a patient, old patients, presented with symmetrical upper motor and lower motor neuron, if you see, if in the exam you get a question, you're like, oh my god, he has atrophy and fasciculations, but he also كمان عنده, like, if it's mixed, ALS. Don't even think of it. Alright? Because there's no other thing that is mixed as well. Yeah.
And since we don't have any sensory and we don't have anything other than its motor problems, we can just
directly think of ALS. True. But كمان when we say motor, we have to think كمان of SMA and poliomyelitis. هلا poliomyelitis is ما في infection, you can easily be like.
No, I meant like we can think like what I meant is that since it's motor, it's gonna be corticospinal tract.
Yeah. بس I mean إنه كمان بالmotor في عنا كمان it might be مثلا polio.
Yeah.
But in polio, we don't have the upper motor neuron signs, right? We only have the lower motor neuron signs, and it's asymmetrical, so it's not that. It's exclusion, alright? So you have to have the understanding of it to know how to answer. Clear? Tamam, next. Do you have questions?
Yes, who of us, other than old, affects both upper and motor?
Pseudobulbar, do you want to ask what the show?
بس I'm picking off the cues that I need to read in questions to understand what.
Yeah, totally. That's smart.
هلا
for this upper motor neuron, lower motor neuron signs, old, and this pseudobulbar is kind of it's very specific. But I don't know I think it's advanced for you, and I don't think in the question they're going to mention it. But what is pseudobulbar palsy? It's basically it's going to be dysphagia, this arthria, and the uncontrollable laughing and the.
Why is there uncontrollable?
Laughter and crying. Okay, so basically pseudobulbar palsy. It involves something with the vagus nerve, alright? Because عشان هيك عندنا dysarthria and dysphagia. Okay. Why exactly there is laughter and crying? I have zero idea. But I think if there is an inhibition, there is a palsy to the pseudobulbar nuclei or whatever that is. So this usually does an inhibition or kind of like calms down the person. So they're going to have uncontrollable fits of these things. Alright? If you see this command, this is very, very specific for ALS. So if you see that, then keep it in mind. If you see someone that's just laughing and just on all think of pseudobulbar palsy, then it's ALS. Okay? So, you know what is the other name of ALS? Lou Gehrig's disease, because it's the very famous, I think he's a basketball player or something, I don't know. But he got the disease, okay, and then he was, it was named after him. And who's another person who's really famous and has ALS? Stephen Hawking. So this is how it is. So basically in ALS, what happens is basically it's like a neuroimmune disease where basically they're starting to affect the structure of the nerves, damage the body is going to start to damage the nerves, Hello, for we're going to have damage, we're having atrophy, the nerve is no longer going to be viable, and all of these are possible, and eventually they might need ventilation and stuff, because if the diaphragm is affected, then خلاص يعني they're going to be needing يعني.
But I have a question. So, like, what is the reason for ALS to happen in the first place?
Superoxide dismutase.
Exactly, it's a genetic disease, okay? It's a genetic disease, and basically it's autoimmune. And your body will start attacking itself. You get me? It will start attacking the nerves, and it's gonna get damaged. It's something you can't control. Yeah, that's why ALS is untreatable. You can manage the symptoms, you can prevent it from progressing further, but you cannot treat it, fully treat it. Okay? This is ALS. Is it clear up until now? So, خلاص. This is the motor. Clear?
Yes.
Clear. Yalla, who's gonna read this case? Yalla.
A 54-year-old presents with progressive unsteady gait, stabbing leg pain, and frequent falls. He struggles with the balance in the dark and has poor coordination. On examination, he has a positive Romberg sign, absent deep tendon reflex, and reduced proprioceptions. His pupils are small, irregular, and non-reactive to light. Joint deformities suggest Charcot joints, serologic test, VTR, FT-ABS confirms tertiary syphilis.
Ignore the last part, it's advanced, but we need to look at the things that we need. Again, the patient is old, alright? Just leave it, but turn it off. Okay, so the patient is old. Hello? Okay, patient is old. Come on. And what are we having, motor or sensory? Sensory, perfect. What part of sensory? I know you can see it, but dorsal column. Why is it the dorsal column? Because it's not pain and temperature. صح? Is there pain and temperature affected? No. It's just that he is frequently falling. Why do you think he's frequently falling? Exactly, proprioception is gone. So when you stand, proprioception helps you know that you're, okay, I'm standing here in space. But if your proprioception is gone, you're going to be like, unstable. So he has unsteady gait, okay? He has stabbing leg pain, so he has pain, alright? Why do you have stabbing leg pain? That has nothing to do with the sensory loss per se, because we said, what is gone? The proprioception and the height. But syphilis is an infection. The taps dorsalis, whereas syphilis is an infection of the dorsal column. Alright? It's the tertiary syphilis. Do you know what syphilis is? It's a sexually transmitted disease, alright? Do you know the Troponium palladium? Perfect, yeah, Troponium palladium, something like that, yeah. So this is the spirochete that basically transmits syphilis. And this is tertiary syphilis or neurosyphilis. This happens later on in the disease. If the primary and the secondary was not treated, it will eventually progress into neurosyphilis. Okay? So let's go into the symptoms again. So he has he's frequently falling. Specifically, he struggles in balance in the dark because the unconscious, or when you turn your eyes, when you close your eyes, what you feel is you're not conscious. Proprioception is gone. The unconscious proprioception, all right? And he has poor coordination. So positive Romberg sign. Do you remember the test that I told you about? This is the test. Romberg, you ask the patient to just close their eyes, stand, and they're going to start swaying. So if they sway or if they fall, this is a positive Romberg. And they have absent deep tendon reflexes, okay? Why do they have, I know absent deep tendon reflexes might seem weird, but if you look at the imaging here, the dorsal ganglion is affected. Okay, so that's why there's a little bit of like affection of the reflexes, because you know how reflexes go, it's like a loop. Yeah. And then reduced proprioception. Hello. There is something very very specific to tapes dorsalis, which is the Argyle-Robertson pupils. Let me show you how do they look, because this is actually really high yield. It comes in your like step exams. Argyle. Okay, look at them. So the Argyle Robertson. Okay. It's not there here, wait. Okay, so look, in here, basically when a patient comes to your clinic, you want to check when you're doing a neuro exam, you will check his pupils, right? This is part of cranial 2 examination or cranial 3. So when you put the light, you shine the light into it, okay? Usually what happens, okay, when you shine the light into one eye, okay, the other eye constricts too. This is just physiologic, okay? So in Argyle Robertson, what happens is when you shine the light into the eye, the other one stays the same size. It does not constrict. So this is when it's positive. You get me? So you get the light, I shine the light into the patient's eye. Usually, if I shine the light into the left, it will constrict, and the right is going to constrict a little bit. Okay? Physiologic. If I put it on the left and the right does not change size, then that's a positive Argyle Robertson, or like this whatever this is. Okay? Yeah. That's all you need to know. This is extra, by the way. If you don't really need to know that, but it's an interesting information to know. Okay. So this is and we have Charcot joints. Do you know what Charcot joints is? So basically, they're going to have damage to their joints. So, in summary, if we have a patient who's old, okay, he has stabbing pain in his legs. Because this is neurosyphilis, so it's an infection, okay? So that's why there's this kind of stabbing pain. And then he lost his proprioception, he lost his, what else? He lost proprioception, he lost what do we have? Pressure, he lost fine touch, he lost all of these things. You think of dorsal root, okay? So dorsal root is affected, tapes dorsalis. Clear? If we have Charcot joints and this pupil thing, then those are extra points to know that it's neurosyphilis or tapes dorsalis. Come on?
I just have a question that is not recording according to this. There are two things that I think we talked about them, which is the curanate, which is upper arms, and the lower, which is... Yeah, is it part of the dorsal also? Or?
It's all, when I say dorsal column, it's everything.
Yeah. But I think you get what I meant.
Yeah. So basically, you know how in the dorsal column we have the fascicular cunata and the fascicular gracilis. So the gracilis is the one that's for what?
Fasciculus is for the lower.
The gracilis. Lower limb. The cunatus is for the upper limb. Okay. And which one is the one that's lateral? Cunatus. So basically, this is the thing that we're talking about. Related, exactly. So you see this one here, this is the cunatus, okay? This is the most lateral, and this is the gracilis. So let's say, okay, if we have a damage, these things are important when we have a tapes dorsalis, there's an infection of everything, like all the dorsal column. So it won't matter, okay? Because he's going to have loss of pain and, proprioception, pressure, all of these things in both, the upper and lower limb. But where are these important? If we have a lesion specifically in the fasciculus gracilis, okay? Or if they say, there was a knife lesion, and they mentioned that it only cut the median dorsal column. You know, like they're going to give you hints. If they say lateral, you'll think, okay, upper motor. No, not upper motor, I mean like upper limbs, okay? If they say median, you'll think of lower limb, okay? But this is going to be very specific and like a specific lesion, okay? So this is tapes dorsalis. This is just like neurosyphilis. So it's basically tertiary syphilis, untreated tropinopalladium infection. How to diagnose and treat is not important on your level, okay? So there's something called subacute combined degeneration, or SCD. Okay? Does anyone know where does this come? Like, where is this very specific for?
Is it like
sure.
motor and
Before that, have you ever heard of subacute combined degeneration? Yes? What is it caused by?
Vitamin B12.
Exactly. So this is very, this is, then if they get to this case, so I don't read the case, but if you see in a question vitamin B12 deficiency, think of that. Don't even bother reading the question. غير إذا مثلا read the question. مو لدرجة don't read the question. But like if you see B12, the first thing that should come in your mind is subacute combined degeneration. Okay. And what happens here is we're going to have both motor and motor and sensory. Hello. Just look at the actually not motor and sorry wait. So this is an old man. He comes with chronic gastritis and a vegan diet. If they say gastritis and a vegan diet, B12 deficiency. Why? Because vegan diets they don't eat the things, and gastritis, you know how B12 is absorbed. It's absorbed through the IF, remember it? Intrinsic factor, exactly. So gastritis is an inflammation of the stomach. If we have inflammation, then this is going to be disrupted. What happens is no absorption. Okay. He's going to have gait instability, so proprioception gone, numbness and tingling, paresthesia, so he has sensation is gone, okay, loss of sensation, and then he has a positive Romberg. Again, we said Romberg is for proprioception, no vibration sense. He has hyperreflexia and spasticity, so upper motor neuron lesion, right? Low serum B12. So if we have upper motor neurons lesion signs, because look at the area of this.
Yeah.
It's literally in the motor sign, upper motor neuron. Okay. Remember ALS, how it was outside and inside. So ALS, it was on the side. So this is basically. So when you see this with these, think of SCD, like SCD, which is related to B12. Hello.
So since he doesn't have sensation and vibrations, so is the spinothalamic also going to be affected? The
spinothalamic is for pain and temperature.
Ah, wait.
Okay.
The dorsal.
Exactly. The spinothalamic it's not affected in here. I'm pretty sure it's not. It's not because they would mention clearly pain and temperature lost. Okay? They were just saying loss of sensation, where is it? Numbness and tingling. That's it. You know? Numbness and tingling is just loss of sensation. It's like it doesn't have to do with pain or temperature. So again, if old patient, vegan diet, B12 deficiency, or whatever that can cause B12 deficiency, proprioception is gone, vibration is gone, everything that is in the dorsal column with with upper motor neuron signs, we think of subacute combined degeneration. Any questions? Okay, now before the last, I think right now, a couple. I think this is one of the most important ones. Who wants to read? Okay, give her the mic.
Okay, a 68-year-old man presents after aortic aneurysm repair with sudden onset of leg weakness and numbness. Exam shows spasticity, hyperreflexia below the lesion, flaccid paralysis and absent reflexes at the lesion level, and loss of pain and temperature sensation below the lesion. MRI confirms spinal cord infarction in ASA territory, sparing dorsal columns, likely caused by disrupted blood flow during the repair.
Okay, aneurysm. So aneurysm means we have something that has to do with blood. Okay, so we have cessation of blood flow. Hello? Now, together, we want to say which tracts are affected. So, first of all, we have spasticity and hyperreflexia. This is an upper motor neuron lesion, right? Perfect.
And we also have flaccid paralysis.
Yeah, we'll go there. Wait. So, the spasticity and the hyperreflexia is below the lesion. Okay? So, this is, what do you think this is? Corticospinal is affected. Okay. Then we have flaccid paralysis and absent reflexes at the place of the lesion. So if you think of that, remember the place where we said that the first neuron will meet the second neuron and like at the anterior horn where they synapse. So this is where the thing is happening. And if you look at here, it makes sense because this is usually the place where it happens. So this is the place that's affected, okay? So this is gone in both symmetrical. Hello? So at the level of the lesion, lower motor neuron, below the lesion, upper motor neuron. And then we have loss of pain and temperature. So what's affected? Spinal thalamic. No pain, no temperature. So what is preserved? Proprioception is preserved. Everything else is preserved. So what is the structure that's not affected? Dorsal column. So once you see that the dorsal, if you see a lot of things and just dorsal column is spared, just know it's ASA. Hello? Is it clear? So again, what is ASA? أول شيء they might mention in the question إنه في عنا history of مثلا hypertension, anything that has to do with vessels. حلو? That's one. هون حطوا aneurysm. 2. Below the lesion, upper motor neuron signs. At the lesion, lower motor neuron signs. Plus loss of pain and temperature. With preserved proprioception and everything, so directly think of anterior segment is gone. Is this clear? Yes.
How do we have below the lesion upper motor neurons and then at the lesion lower?
Because I'll tell you why. Because نحن when we هلا نحن هون لما يصير في عنا occlusion, everything below it is gone. يعني أنت when you يعني هلا I know إنه this is like a section of the spinal cord, okay? But at that section, the artery stops working. حلو? But what happens is that everything at the spinal cord at the lesion and everything below is affected. It's gone, like hypoxic, no oxygen, nothing. So at the level of the lesion, what do we have at the level? We have the lower motor neuron going out. صح؟ بس everything تحت لسه the upper motor neuron هي اللي لازم تكمل. Like the upper motor neuron is supposed to complete, but it's gone. So that's why, because the upper motor neuron is gone, and the lower motor neuron at that position is cut or it did not receive or whatever, and lower motor neuron. Is it clear? Clear?
Yes, thank you.
Okay, I feel like you're... Why?
Would you mind repeating?
Yeah.
No, I don't mind, it's fine. Yeah, let's start. So, the idea is, they asked, why do we have upper motor neuron lesion below the level of the lesion? So what I was trying to say is spinal cord is continuous, obviously. It's not like only like the section that we have here. So when we have cessation of blood at that point, okay, the blood is going to supply everything in that place. And then the cessation is going to complete all the way down. Because the upper motor neuron, wait. I think I get why you're confused. So let me show you something on the... So this is the spinal cord, right? Okay. Now, this is better. I'm gonna draw on it, so let me show you. Okay, perfect. So, let's say the lesion is right here, okay? Now, the upper motor neuron is going like this. It forms something with the lower motor neuron here, but then it goes down, okay? And then we have a lot of lower motor neurons, blah, 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 okay? Now, what's affected is the lower motor neurons in here, they're not affected, okay? Because if you think of it, what happens is the upper motor neuron has to communicate with the lower motor neuron to kind of inhibit it or activate it, okay? If the upper motor neuron is gone, then خلاص, it's going to be spastic and it will go to do whatever, because it's the upper motor neuron, it's an inhibition of the lower motor neuron. Do you get me?
Yeah.
It kind of is like it regulates. So at the lesion, okay, the lower motor neuron is gone, so we're going to have the lower motor neuron signs, because the upper motor neuron is fine. Then down, okay, at that point, the upper motor neuron and the lower motor neuron met, and the inhibition did not go. The inhibition is still there, but the damage is to the lower motor neuron, so it's gone. You get me? But down, the upper motor neuron is the one that's gone. the lower motor neurons are not affected because they're basically at the part way farther. فلأن the upper motor neuron is the one that's affected, we're going to have spastic below. Do you get me? Like the inhibition by the upper motor neuron is kind of gone.
Right.
Does that make sense, or did I confuse you more?
No, it makes sense.
Okay. So. Okay. طيب, is it clear? Any more questions for ASA? So we can see it here, come on. We don't have much left, inshallah, we're not going to take so much more of your time. But look at here, so basically what happens is, you see how the lateral spinal thalamic is going up, the corticospinal is going down, whatever. So all of this is affected. Now, the T8 at that part of the lesion, okay, the anterior horn of that part of the lesion, specific lesion, is affected. All right. So because the anterior horn is gone, we're going to have flaccid paralysis there, because that's where the lower motor neuron is. And then if you look at the rest, the affected area, the lateral corticospinal tracts are affected. So the upper motor neuron that is there is gone. Alright? So that's why, because the upper motor neuron there is gone, everything below that is going to have spastic. Because the upper motor neuron inhibition is gone. Alright? And last but not least, we have the spinothalamic tracts. That's why we have loss of pain and temperature sensation all over. Clear? Yeah, sure.
المشكلة كلها إنه spinal artery is occluded.
Yeah, the anterior spinal artery.
أيوه. If it's occluded, that will also affect almost all the levels above it, صح ولا لا?
No, it's only down because basically
the blood supply.
Blood supply is fine until here. It's occluded here. So everything above is fine.
How is it fine?
يعني think of it like that way. It's like مسدود.
ولا فوق القلب؟
إحنا تحت القلب.
لو كنا فوقه.
حتى لو كنا فوق. ما هو how does the blood go? This is the heart, and it goes all the way like this, and it's like a circle, right? Circle back to the veins يعني. The arteries, they are going down. فإذا أنا I included a part of the arteries من تحت.
حتى من الدماغ؟
لا الدماغ is different, I guess.
لأنه أنا I'm saying
I got what you mean.
cervical. خلينا نتخيل الcervical.
Okay.
I imagine the blood supply
going up.
It's not downwards.
But in this case, it's going downwards if you think of it.
Because we're thinking about the nerves. That's
vertebral.
Yes.
True. Let me just show you how does it go. Usually, it goes. So this is the carotids, right? The carotids are going to go. You're going to give the basilar, right? From the basilar, we're going to have the vertebral. The vertebral are going to go wee لتحت. You get me? But the vertebral are the ones that are going to be affected here. But they're going down. If anything, concluding it, black is going to be a lot of nothing going down. Do you get what I mean? Because it's going to loop. I can open an
How
image.
can it affect the...
You need to go.
It's going down, not up.
Wait, let me show you.
We need to leave, but thank you so much. The session was really amazing.
You're welcome. I'm so sorry I'm taking so much of your time. Okay. Look in here, okay? Hello. What happens is these are the carotids, right? The carotids are going to go up. And then they're going to form the circle of Willis. هلا in the circle of Willis we're going to have the basilar artery, right?
Can you talk in the mic?
Yeah. So basically they're going to go into the circle of Willis, and then from the circle of the Willis they're going to form the basilar artery. Now the basilar artery is the artery that goes into the medulla, right? And then from the basilar artery we're going to have the vertebral arteries. But it's looping down.
So
do you get it?
cord is supplied من فوق لتحت.
Exactly.
Okay.
You get it?
So this is how it affects the medulla too.
What do you mean? Like usually?
ASA occlusion might lead to median medullary syndrome.
Yeah, it depends on where specifically. Exactly. If it was up مثلا عند basilar, close to the basilar, yeah, it might affect the medullary. You get me? Because the medulla is, احنا عندنا basilar artery and then we have the pica أشياء. I don't really remember this stuff. I did not revise them for this session. But as these are included, yeah, they might affect my field.
بس المايكا affects the natural مش الميديا.
Yeah, I'm not sure which one. بس إنه do you get what I mean? إنه from the base layer بصير فيها يحسب which one of these might be affected. Do you get me? تمام. هلا syringomyelia. Do you remember where we mentioned syringomyelia before? اليوم. Clear information. Perfect. So syringomyelia. Where did I leave my point on? Syringomyelia. Hello. It's basically. It's also called anterior cord syndrome, I think. No, the other one is central cord syndrome. My bad. It's called central cord syndrome. So the idea of syringomyelia is that we have a fluid-filled spinal cord, like you see in here.
No, they're different, aren't they?
Then central cord. Central cord can be caused by syringomyelia.
I'm pretty sure Dr. Yoqin
So they're different?
separates them like
Really?
completely. Yeah.
Maybe central cord can happen anywhere.
I don't know.
Never mind.
He said something about like there's a distinction
Between them?
To him, but I don't know how. But
I can look up into it like later on.
But I remember going to his office about it, and he separated them like completely. So just to put that out.
Is he here or did he leave?
I think he left. Anyways, هلا مو هالفكرة. شيء كان forget what I said about the central cord syndrome. Let's focus on syringomyelia. حلو. Syringomyelia, it's basically, you see this yellow thing in here, we're going to have a fluid-filled cavity in here. حلو. And this happens specifically at the anterior white commissure, alright? So the anterior white commissure in here is going to be, like, this fluid-filled thing is going to push on it. حلو. But it's going to kind of affect its function, okay? Because it's like pushing on it, adding pressure on it. So what happens is we're going to have this cape-like structure of, cape-like distribution, of loss of pain and temperature and sensations. طيب, and this usually happens around level of C4 to C5. So what's going to happen is we're going to have this cape-like. If someone, the case is going to be something like someone presented to the clinic with loss of temperature and bilateral loss of temperature in their upper hand, in their neck and their upper limbs, and that's it. And they might mention cape-like if they like you, they wanna help you. But into the hack, you have to know if it's only upper limb, bilateral, and it's just remember the cape and how you put it, and just know it's syringomyelia. Okay? Why is it cape-like? It's because it's affecting the anterior commissure. Okay? So this anterior white commissure is compressed, and because it's compressed, we have this. Clear? Perfect. Everything else is whatever. If the syringomyelia is really big and it really progresses, it can affect the anterior horns and causes lower motor neuron lesions. Okay, because look at it. This is where it's happening. Okay, we have if it goes bigger and bigger. Okay, it can affect it can affect the anterior horn right here and right here. Hello. So if the anterior horn is affected, then what will have lower motor neuron lesion. Okay, because remember the synapse and the lower motor neuron leaving. Yeah. So that's it. Now, brown sequoid lesion. Who wants to read that? Give her the mic.
Not reading about.
Oh yeah, sure.
Yeah. So central cord syndrome and syringomyelia, it's different etiologies, so a different pathophysiology, but they share characteristics because the central part is affected in both.
Okay.
Yeah,
perfect.
There's usually a sacral sparing.
There is sacral sparing and central cord, right?
Yes.
Yeah. So what is it called? So I'll just mention what your colleague mentioned, okay? So here basically we can't say that the syringomyelia equals central cord syndrome. Okay? ليش? Because the etiologies and the pathophysiology is different. Okay? So whatever causes syringomelia is different than the causes of central cord syndrome. But the presentation is similar, alright? That's all you need to know. Okay, we're on the sacral sparing and the central cord syndrome, right? Is it clear?
I'm kind of confused.
Listen, so central cord syndrome is something, syringomelia is something else. The only thing that is in common, presentation. يعني both of them are going to have مثلا bilateral loss of pain and temperature, or if it was severe, it might affect the anterior horns and the lower motor neuron lesions. That's it. Okay? يلا, who's gonna read this? Read it.
A 34-year-old man presents after a knife injury to the lower back. He reports numbness and weakness on the side of his body, with pain below the injury. On examination at the level of the lesion, he has ipsilateral loss of sensation and flaccid paralysis, while below the lesion he exhibits ipsilateral spasticity, hyperreflexia, loss of proprioception, vibration, and fine touch, with contralateral loss of pain, temperature, and crude touch. He also presents with ptosis, meiosis, and hydrosis. Above to you.
Okay. So we have everything that ever exists on Earth right here, right? So let's recap. Usually this always comes with knife injury. When you see knife injury to the back, bronchosacard لازم يشتغل على your خصوصي because they say unisection. Sometimes they say unisection of the back or knife to the back or whatever. If you see this is very like key, like a key. You hate to think of it. Now we have numbness and weakness on one side of the body. Numbness and weakness, so loss of sensation and loss of movement, right? And with pain below the injury. So we have loss of sensation and weakness. And then on examination at the level of the lesion. So at the level of the lesion. Let's ignore this. طيب. Let's ignore this and go in here. Okay? Let's go in here. If we have a hemisection of this, okay, all of this is affected. Do you see it? What do you expect to see? Let's start with at the level of the lesion. What are we going to see?
Bad anesthesia.
Okay. Gone off all sensations. Ipsilateral, all the sensations are gone. حلو. What else? At the level of the lesion.
Lower motor neuron, corticospinal.
Lower motor neuron. Perfect. طيب. Okay. This is at the level of the lesion. So let's check. I'm pretty sure we're right. Yeah, شايفين? Loss of all sensation and lower motor neuron signs. طيب. هلا. In here, what do we have? We have the spinothalamic, we have the corticospinal tract going up, going down, sorry. We have the anterior horn, and we have the lateral spinothalamic tracts, right? Now, let's remember, spinothalamic tract, where does it decussate?
Spinal cord.
Spinal cord, at the side of the head, صح? So where do we expect the pain and temperature to be lost? Contralateral. So at the other side, we're going to have loss of pain and temperature. طيب, at the same side, what's going to go? Exactly, everything except the loss, and we're not going to have loss of pain and temperature, we're going to have loss of proprioception, vibration, everything the dorsal column has to do. Okay? Because again, remember, dorsal column, where does it decussate? For medulla. The corticospinal, where does it decussate? Medulla. Okay? And we're going to have spastic paralysis. Where will the spastic paralysis be? تحت the lesion at the same side, ipsilateral. Why? The same idea of ASA. Because basically at the point where it goes, the lower motor neuron is affected. But everything تحت, the upper motor neuron inhibition is gone, so we're going to have spasticity. تمام? Now look here, if you look at it, we have upper motor neuron sign is affected, we have impaired proprioception, vibration, and fine touch, and then this is at below the lesion. On the contralateral side, we're going to have the pain and temperature gone. Why? Again, because it decussates at the spinal cord. Okay? Is this clear? That they love this. This is 100% coming in the exam. Yes. Is it clear? Yes. 100%.
So in anterior, basically, in anterior ACA, which happens occlusion, so I feel like I'm kind of lost with the last three lesions because like they're kind of pointing.
So listen, ASA, what happens is we're going to have bilateral loss of shoe. The corticospinal is gone, so we're going to have lower motor neuron at the side and upper motor neuron تحت. we're going to have
Yeah, why is it upper motor?
Why upper motor neuron تحت? Because I mentioned an upper motor neuron, it goes all the way down. If the inhibition is gone,
so
فبصير في عنا spasticity. بس at the same side حيكون flaccid. حلو؟
Flaccid, yes.
Is it clear, guys? This is for ASA. Hello? Like you see ASA here, again, the pain and temperature is gone. ليش؟ لأنه عندنا السفالوثالاميك. طيب؟
Can I say something? If you want you can finish عشان
okay.
بعدين if you want أنا إذا ما عندك مشكلة فيني.
Yeah, no problem. تمام يلا. Brown sacred is clear.
Yes.
To everyone. أكيد. If you get that question wrong in the exam, حأزعل منكم كلكم. يلا. Frederick ataxia. I'm gonna just give you the. I don't know if did the doctor cover it for you?
Yes.
Okay, خلاص. Who wants to read? No one? خلاص I'll read it. That's fine. So basically, it's usually a young patient. You will come with history of falling. Why does he fall a lot? Proprioception. Okay. Difficulty walking, progressive clumsiness over the past few years, staggering gait and difficulty speaking, and a positive Romberg sign, nystagmus, ataxic gait, pascavus, hammer toes. All of these are keywords for Frederick ataxia, by the way. Loss of deep tendon reflexes, impaired vibratory sense and proprioception. Cardiovascular examination shows hypertrophic cardiomyopathy. هلا إذا جابوا لكم كيس فيها hypertrophic cardiomyopathy, just put Frederick ataxia. Don't even bother reading. Don't even bother thinking. Okay? Especially that it's a young patient. Only if it's a young patient. Ataxia, Romberg, all of these things. Come on, Frederick ataxia. Because the name is Frederick ataxia. So there's ataxia. What does ataxia mean? An issue in the cerebellum. Cerebellum. There's an issue in the cerebellum. Hello? You can see in here the thing that is affected. The dorsal column is affected. The corticospinal is affected. Hello? But that's why we're going to have the, what is it called? Actually, corticospinal is not affected. These are the, what is it called? Not spinal.
Corticospinal is affected.
It is affected, but not fully. Because, wait, let's see.
Are you talking about the the extrapyramidal tracts?
Yeah. This one here, like you see the image, this is the dorsal column, okay? مع الهاي. That's why شايفين هدول. It's like it looks like tapes dorsalis. That's why we don't have tape. The deep tendon reflexes are gone. My question is these two. What do you think these two are?
Corticospinal?
Let me double check. Because, yeah, I think it is the corticospinal. Yeah, they are the corticospinal. But the thing is, he doesn't have...
He has spastic paralysis.
He does? Where is it written?
أنا ما قرأت الكتاب، أنا كاتبه في الكتاب وقاعد أقرأ.
Oh, okay. That makes sense. I missed it in the thing. No, it's totally okay. It's totally okay. I used this thing to make the case. Like, I copy-pasted it, but they missed it. I don't know why. So he's gonna have spastic paralysis too. Okay? So this spastic paralysis will make sense why the corticospinal is affected. Okay? Clear? So Frederick ataxia, you have ataxia, Romberg, positive Romberg sign, he's going to fall a lot, proprioception is gone, pressure is gone, plus he's going to have hypertrophic cardiomyopathy with the pascavus and the hammer toe, and all of these, and the scoliosis. So
diabetes too.
True? Diabetes, true. But I don't know if they mention that. Like sometimes they don't, you get me? No, like I'm not sure if they will do, but usually they do mention the scoliosis because it's really prominent. They do mention the hammer toe and the pascavus with the hypertrophic cardiomyopathy. Hello? This is everything about Frederick ataxia. So you see we have ataxic standing gait. We have excavatus, which is the pascavus, which basically is the foot is like that, and then we have hammer toes, areflexia, deep tendon reflexes are gone. There is diabetes, hypertrophic cardiomyopathy, and dysarthria. Okay. Now the last thing is the cerebral palsy. What do you think cerebral palsy means? We have. Okay, cerebral palsy. So palsy that originates from the brain. Okay? So, is there a question? cerebral palsy. You took it in MSK, I'm not
I
sure.
don't remember.
Basically, cerebral palsy, it's part of the brain that is gone, okay? Whatever part of the brain. And when we say part of the brain is gone, whatever it controls is going to be affected. So we have monoplegia, where basically only one part of the body is affected. We have hemiplegia, where half of the body, in hemiplegia, think of it, hemiplegia means all of the hemisphere of the cerebrum is gone, okay? Because that's why like the sensation and the motor. Diplegia means only the legs, and quadriplegia means all of the four limbs, okay? Cerebral palsy usually is a genetic disease, or actually it's not a genetic disease, sorry, it's usually caused by hypoxic issues in the during delivery, if there was any hypoxia, if there was, there's a lot of different causes for cerebral palsy, alright? You don't really need to know that, just know in cerebral palsy can be either monoplegia, diplegia, hemiplegia, or quadriplegia. Know what does that mean? Mono, one limb, okay? Hemi is the full like side. Quadriplegia is four limbs, and paraplegia is both lower limbs, okay? That's it.
I think you meant diplegia, the lower limb.
Diplegia, yeah. But حتى paraplegia, I think it means both. I'm not sure.
Paraplegia is both
legs?
lower. Yeah.
Hey, both lower, yeah. It's diplegia or paraplegia. It's the same.
Diplegia is both upper or lower. Like it could
Hey,
be-
two limbs. Yeah, symmetrical two limbs. Paraplegia specifically two lower limbs.
Yeah.
Perfect. Hala, we're done with the lesions. Is it clear for the lesions? Any questions?
Can we recap the lesions with like its most prominent?
Yeah. 100%.
صراحة
Let's go through.
like the lesions is a little bit difficult.
Obviously it's difficult, but صدقوني it's not that hard. يعني once we, let's put مثلا, okay, polio, yeah.
Can I test my notes by telling you everything I wrote about each case and tell you if I missed one, and this way we can both answer both questions at the same
Okay.
time.
بس كمان بعطيك مثلا two cases وبعدين حتى تاني two cases, okay?
ما في مشكلة.
يلا start. Polio, what do you think?
بوليو أهم شيء يكون عندنا كد ويكون asymmetrical.
Okay, so asymmetrical loss of what? Motor. It's asymmetrical weakness.
Yes.
So if we have asymmetrical weakness, and once we have asymmetrical weakness, but all of the sensations are intact, what do you think? Polio. Tamam? This is polio. What's the difference like, between polio and SMA?
SMA starts at one limb بعدين يكمل للباقي.
They happen together. It's not من one level بعدين الباقي. They usually progress together. Oh, but so you can, they said it started from one and one to other? No, it starts from the beginning. Both of them are going to be gone. Why are you confused?
The moving one. The book says different.
The book says it's moving?
No, it says it starts at one limb, then progresses into all the other limbs.
It isn't progressive, but it's symmetrical usually. Yeah, I don't think it only starts at one limb. It has to start with both limbs, and then it might go to the other limbs, but it starts symmetrically. Because that's the only difference between this and polio. And this is كمان based on the book.
And what the doctor said. I remember you saying.
Is the doctor said كمان هيك شيء?
Yeah. The same thing you were saying.
The same thing I was saying. Pseudobulbar, yeah.
Yes. You mentioned it, but it's not right.
It's not here. The pseudobulbar is not here. Maybe you're telling me something else. You're talking about this.
pseudobulbar is this.
I think you're reading your ALS notes.
أنت بتقولي إيش؟
I'm talking about SMA.
Okay.
Okay. Yeah. خوفتني. Anyways, SMA, as we said, it's symmetrical. Okay. Weakness and both, and they start together. And they're usually in a baby. Floppy, lower motor neuron. Right? This is SMA. And then, you know what? I'll just revise them myself أحسن عشان ما نخربط بعض. Okay? Is it clear? It's okay.
But can we talk about like both of these are motor tracts? Which
Yeah,
is
yeah.
the
Vertigospinal.
tract.
Perfect. Then we have the amyotrophic ALS. ALS, we have spastic and lower motor. So we have upper motor neuron lesion, yani our characteristics, with lower motor neuron lesion in different parts of the body, alright? With pseudobulbar palsy, which we said is dysarthria, dysphagia, and uncontrollable laughing and coughing or whatever they said. This is the thing. But upper motor neuron, lower motor neuron, pseudobulbar palsy. Perfect. This is ALS. Okay. Usually we're all patients. تمام. And it's progressive. إنه يعني it gets worse.
It's also autoimmune disease, right? I remember you said.
I said that, but يعني don't take my words.
I don't need to know the reason why behind it. Just I know this in it.
Yeah, because it might not be an autoimmune disease. That's what I remember. I'm not sure. Anyways, tapes dorsalis, neurosyphilis, an old patient come on. He's gonna come with proprioception gone, positive Romberg test. حلو. Proprioception with deep tendon reflexes are gone كمان. ليش؟ لأن the dorsal column is straight. Sorry, the ganglion is straight affected. And that's it. So the dorsal column is mainly affected bilaterally. حلو. This is tapes dorsalis.
And
Next.
pain, does he not feel the pain? Other than
Yeah, there is radicular. There is what is it called? Stabbing leg pain. Okay, but I'm not sure if they're going to mention that. Yeah, stabbing leg pain might be mentioned, might not be mentioned. But this is the most important thing. Dorsal column feeling, so loss of proprioception, loss of vibration, and so on. Bilaterally, deep tendon reflexes are gone. Usually he's sick. تمام يعني إنه he's old يعني 55, 56 هيك شيء. تمام وهلا والpupils. Do you remember the pupils? So I don't know if they're gonna mention it because this is extra. But again, as I told you, they don't constrict. Both eyes don't constrict with light. Okay, اللي هي Argyle Robertson pupil. With Charcot joints. Charcot joints are not the best because كمان موجودين بمكان ثاني.
But doctor mentioned Charcot.
Yeah, but like I mean, it does not differentiate because كمان عندنا Charcot joints and another thing. You get me?
Yeah.
But it's nice to know.
Which one that we have Charcot?
Wait, let me check. I think it was كمان هلا Charcot joints كانت earlier موجودة I think so. هلا
Diabetic myopathies.
yeah بس كمان wait I'm scared انكم تخربطوا بين الشاركت والباسكافس. Don't. Okay? يعني Charcot joints think of مثل ما قلتي tapes dorsalis, alright? إذا باسكافس is Frederick ataxia. تمام؟ بس خلص خلوا إذا يعني check it بصراحة it's okay. You can keep it in mind. But I don't know if they're gonna get in the question or not. Like sometimes they're delulu, okay? Then we have subacute combined degeneration. Subacute combined degeneration. Again, someone who has B12 deficiency, vegan, gastritis, takes medications for his stomach. Maybe ممكن يقول لك هو ياخد ابرزول، بياخد شغلة. Oh, it can be even a diabetic, because metformin can cause B12 deficiency. Okay, something that can cause B12 deficiency, and he has symptoms of proprioception is gone, and he has what is it called? Upper motor neuron lesion because of the corticospinal. So عنده spasticity or hyperreflexia. Okay, so spasticity, hyperreflexia, dorsal column gone. مع B12 deficiency, subacute combined degeneration. Next.
And the reason why it's upper motor, it's because of the fact that corticospinal is not working.
Yeah. Anterior spinal artery at the site of the lesion. Okay, at the site of the lesion, we're going to have lower motor neuron symptoms. Okay. Below that, we're going to have upper motor neurons. So at the site of the lesion, it's going to be hypotonia, hyperreflexia. They're going to be should be as flaccid paralysis. Below, it's going to be spasticity, spasticity and hyperreflexia. Hello. And what will be lost? Pain and temperature. Because in anterior and ASA, what is preserved? Dorsal column. Exactly.
Dorsal is
for pressure and proprioception والقصص, these are going to be intact. So pain, temperature, lower motor neuron at the site of the lesion, upper motor neuron at the lower below the lesion. Perfect. This is ASA.
And the reason why we're gonna have lower motor lesions and hypotonia, it's because like when you stab, you ruined the spinal cord, the anterior horn, I guess.
Yeah, right? Anterior horn at the point. تذكروا كيف إن lower motor neuron goes from there. بس upper motor neuron تنزل لتحت. حلو؟ هلا next هي نفسها ASA. على السريع, so we said at the lesion we have flaccid paralysis. Below it you have spastic with loss of pain and temperature. Next, syringomyelia. Syringomyelia, it will affect the anterior commissure, right? So the anterior white commissure is going to be compressed. So what will be affected? Loss of pain and temperature when upper limb. Keep like, so both upper limbs. Hello? This is it. Next, brown sequard at the place, so brown sequard. Ipsilaterally at the lesion, we have loss of everything. We have lower motor neural signs. Below that, ipsilaterally, we're going to have upper motor neuron size with impaired proprioception and vibration. Why?
You said
No, ipsilaterally. On the same side.
At the same side, we're gonna lose everything, right?
No, at the same side of the lesion, we're going to lose everything. Below it, we're going to have spastic paralysis, upper motor neuron signs, and we're going to have impaired proprioception and vibration. Why? Because in the dorsal column decussates at the medulla, so it's going to be ipsilateral. Hello? But we said which tract decussates at the spinal cord? Spinothalamic. So we're going to have contralateral pain and temperature loss. This is Brown-Séquard. Then we're going to have Friedreich ataxia. It's basically a small child, hypertrophic cardiomyopathy, diabetes, pes cavus, proprioception is gone, weakness, okay, كل هالقصص. Then think of kyphoscoliosis, think of Friedreich ataxia. Okay, clear? That's it for the lesions. Cerebral palsy is, they're not going to ask you about cerebral palsy صراحة. Okay, هلا باقي is so easy, just clinical reflexes.